students and also the members to start the class.
Okay. Good morning, Dr.
Sir, your
Sabnish.
voice is, please unmute yourself, sir. Please unmute. Unmute yourself, sir.
Beg your pardon? Any problem?
No, you're audible, sir. You can proceed.
Okay. So, Dr. Sabnish, moderator, teachers, and students. These all topics are of practical importance, and Viva also questions are asked. So, what are the fallacies? What are the precautions? Say before IVU. What are the in air ultrasound, which hurt for the superficial, which for the deep tissue. So these are the simpler things. What for the Dopplers? You have to have very clear. Either in the exam, you have to say yes or no. For the MRI and for the CT scan, you have to understand the basics of physics. That what is happening, and every day there is a change in the this technology. So you have to pay par with technology changing and understanding the basic physics of all these radiological procedures. Biostatistics, of course, we have less knowledge, but it's important for all the research purposes and various issues. So be very serious, calm and quiet, and ask questions if you can't understand. So thank you everyone again, and I hand over this to moderator. Please go ahead.
Thank you so much, sir. A very good morning to everybody. It's a Sunday morning, and we are discussing very pertinent topics about the use of radiology and the importance of radiology in the practice of urology. And I have the pleasure of having with me Dr. Anurima Patra, who's a consultant of radiology at the Tata Medical Center, Calcutta. Dr. Puneet will be joining us in a short while. He is a senior consultant of nuclear medicine at Apollo Clinicals Hospital, who will be talking about the DMSA and the DTPS scans. And I would also request him to touch upon the PSMA, which is a very important topic these days. And Dr. Shabnam Ara will be taking care of the basics in biostatistics, which again is a very important aspect because urology without research is nothing. So the planning for today is somewhat like that. We have arranged certain questions, and I would request the students to be very vocal, and if they do not have if they are not clear about something, please be you can ask any number of questions. We do not have any time restriction. And may I have the students for the day? Dr. Shubhajit Malakar, are you there? Dr. Mrinal, Dr. Shubhajit Malakar, Dr. Sachin, and Dr. Nandish. Can you just unmute yourselves? Hi, can you introduce yourselves?
Myself, Dr. Nandish Kumar from IGMS Patna.
Hi, Dr. Nandish. And Dr. Sachin Sharma, Dr. Mrinal. Do we have them with us? Any other students who have joined? Shashi, I think you're there.
Yes, sir.
So would you be eager to join as the student for today?
Yes, sir.
Anybody else who's there? Students? Right. So with Shashi and Nandish, let's first of all start the first part of the today's topics, and I hand over the proceedings to Dr. Anurima Patra.
Okay.
Today we are finding some network issues. It's breaking.
Okay. Am I audible right now?
Yes, you are audible in this.
Okay. Okay. So, okay, I have a few cases. Maybe I can share my screen. I have a presentation with me. Okay. So, how many students we have to take these cases with us?
First of all, we have Dr. Nandish and Dr. Shashi who will be answering these questions.
Okay. Okay. Can you see my screen here?
Yes, very well.
Yes.
Please proceed.
Okay.
Yes.
So we'll basically look at different pathologies. We look at a few cases one by one. I guess one of all the students can take up one case, and then we can discuss. So here's the first case. The history is on your screen. So whoever is taking Dr. Shashi.
Yes, ma'am.
So
Yes,
this
ma'am.
one, the first case is for 9-month-old baby who has a weak stream of urine. Okay, so you have the history on your screen, and ultrasound was done. It suggested bilateral hydroureteronephrosis and bladder wall thickening. So then another study was performed for this kid. Can you name this study?
This is RGU film.
Okay, RGU full form,
Retrograde urethrogram.
retrograde urethrogram. Okay, so what do you think is happening here? Why do you call it an RGU? And what do you see here on the image?
We identify pathology in anterior urethra, mainly in retrograde urethrogram, and in this, although bladder is not fully visualized, but posterior urethra is dilated, and anterior urethra is not well distended. So it's and the history and this picture is according to the posterior urethral valve.
So do you diagnose a posterior urethral wall on a retrograde urethrogram or on a
MCU,
voiding?
micturating
Yeah.
cystourethrogram.
How do you differentiate between an micturating cystourethrogram and an RGU based on this image? Can you differentiate between the two?
In micturating cystourethrogram, bladder is filled with contrast and posterior urethra is well opposite.
Right. So do you see the bladder here on the screen?
Not fully.
Can you see part of the bladder on the screen? What is this
Yes,
structure? This opacified structure?
This is bladder along with irregular wall bladder.
So you can see that the bladder is distended with contrast, right?
Yes.
Yeah. And it's fully distended.
Ma'am, I differ a little bit because the posterior urethra is well opacified and distended, and bladder is well distended. So it seems to be MCU film rather than RGU film, and there is no infant feeding tube or something to inject contrast into anterior urethra. So it's MCU film.
Correct. So you have to look at the bladder distension, right? When you do an RGU, you will not see this kind of a distension of bladder, right?
Yes.
Yeah. So how do you perform an MCU? How do you do it? So when you have a suspicion of a posterior urethral wall, you will order an MCU, right?
Yes, ma'am.
Okay. So how is this procedure performed?
This procedure is performed straightforward. If we have to do MCU and patient is on SPC or some catheter, we inject contrast tazograph like 76% or 60% into bladder. Fill it. The bladder is filled with the contrast, and some NS contrast may be diluted depending upon the need, and the bladder is filled with the contrast. Then we have to take first the static film, and then patient is asked to void, and then we have to fill the micturating film, and after that micturating film we have to take the post void film.
Yeah, our batchmate classmate.
Sorry, did someone say something?
No, that's a site of Panorama. You please carry on.
Okay, so so you will basically catheterize, right? How do you inject the contrast?
In case in posterior PUE, we can insert catheter because most of the cases are type 1 valve in which catheter is easily negotiable, or infant feeding tube is easily negotiable into the bladder. And since we can negotiate the catheter, we can fill it with the contrast, and then remove the catheter and take the static film, and then a widening film, and then a post-wide film.
Okay, why do you need these 3 films? What do you see on each film?
In a static film, we can comment about the bladder, whether it is trabeculated, any diverticulum, on smoothness of the bladder wall. And in the dynamic film, we can comment upon the bladder neck and the posterior urethra. And in post-wide film, we can comment about the status of the residual volume in the bladder. And in micturating, also in dynamic film, we can comment about the reflux, if there is reflux going in the ureters.
Okay, right. So we also comment on the reflux, like on the static film also, when you distend the bladder with contrast, in that film also you have to look for any vesico-ureteric reflux, right? So we also image up to the kidneys, level of the kidneys, right? Because we need to see the renal pelvis. If there's reflux which is going till the renal pelvis and also causing hydroureteronephrosis, right?
Yes.
So what contrast is used for this study?
Sodium diaprogate, 76%. We here practice 76% tazograph, and that is mixed with the normal saline. And the bladder is filled up to 250 to 300 ml volume.
Any other contrast agent that you can use for this study? So are you aware of any low or smaller non-iodinated contrast agents?
Yeah, iohexol or
Okay, so I mean, you must be aware of the CT contrast agents, right? The contrast agents that we use for IVPs and CT scans, right? You can use those contrast agents as well. You have Omnipaque, iohexol, right?
So there's a question in the chat box. What are the prerequisites? I mean, what is the most important thing which you will check before doing any kind of an RGO or an MCO on a child?
The urine culture should be negative. So because before doing RGOMs, we should assure that the urine REME and CS is negative.
Correct,
So
correct.
active
So you
infection
have
should
to
not be
get a
there.
urine culture done. Yes. Please proceed.
Okay. Tarun sir, you have any questions on this image?
No, not really. Anybody else would like to ask any questions? If Dr. Sabnis is there, if you would like to ask any questions on the RGO and the MCU. So I think we can proceed with the next presentation.
Yeah, okay.
Next,
I think you guys should be like, you guys can read up these fluoroscopic procedures, because you should be fundamentally able to differentiate between an RGO and an MCU. That's very important. If you do not identify the study correctly, then everything else is going to go wrong, right? So you should be able to differentiate between the types of studies and how the procedure, how they are done, what are the indications and what are the contraindications of the procedure, right? These should be like on your fingertips. Okay, so we move on to the next case. Okay, so who wants to take this? A 50-year-old man with left flank pain.
Yes, ma'am.
Dr. Nandish can take maybe,
Yes.
if he's there.
Yes, sir.
Dr. Nandish?
Yes, sir.
Yeah.
This is a contrast film showing the right side of PCS and normal excretory with ureter normally excreting filling the ureter, and the left side there is hydronephrosis, along with the ureter is also dilated up to the lower ureter, where we can see an radio opaque shadow maybe ureteric stone. So diagnosis is left ureteric stone with hydroureteronephrosis, proximal hydroureteronephrosis.
See,
Right, left.
my one suggestion from my end would be that do not commit upon a stone or any other diagnosis on seeing just one single film.
Okay.
So these are going to be always red herring. So you have to basically ask that, can you please show me other images of this patient? So
Okay.
this might be anything. This might be a stone, you might be correct. This might be a stricture, this might be anything. So you need to have a sequence of images. Do not commit a diagnosis based upon a single image.
It could even be just contrast, right?
Yes, sir.
Correct, right, sir. So when you see this film, would you ask for any additional film?
First, I would advise him for the plain X-ray KUB, and then after the image, I will shoot from the sequential images after 15 minutes and 30 minutes and after 24 hours.
Okay, so you would first need a non-contrast CT,
Yes.
radiograph, right? Non-contrast radiograph, KOB. So what study is this? What do you call this study?
This
Is
is
this just a KOB X-ray?
this is IVPS study, intravenous pyelography.
Yeah, okay. I would also suggest that you do not use short forms in your exams. You should always elaborate, right?
Yes.
When you're mentioning something first. So what study is this?
This is intravenous pyelography.
Okay. So when somebody is showing you this one film, you will always ask for a non-contrast, right? Why do you need to see non-contrast? Like sir just mentioned, you have to look for any radio densities, right?
We have to, yes, we have to differentiate between radio density and contrast.
Right.
So can somebody tell us the procedure as to how an IVP is done? What is the dye used and what is the amount of dye that you give for an IVU? And how do you make the ureters prominent on an IVU? Shashi,
First,
maybe, yeah, tell me, proceed, Nandish.
first we have to take the plain X-ray KUV film.
Correct.
Then intracath is put, and IV contrast is given. We can use a 76% tazograph with volume is 1 ml per kg body weight, and then we have to take the sequential excretory films.
So what is the sequential imaging that you use? What is the time at which you take the images?
At first is at 1 minute, and then at 5 minutes and 15 minutes.
Nothing beyond that.
And then we have to take film at post-wet film and after 24-hour film.
Right. So you need to have a post-wide. So the sequence of the time varies. So you have a 30-minute, so you have a 1 minute film, you can have a 5, 10, 15-minute film, you can have a 30-minute film, even a delayed film. But the most important thing, you also need to have a voiding film. So if you want to have an entire, a good IVU. So what are the prerequisites before you do an IVU? So Dr. Ranveer Singh sir has asked, what are the prerequisites to have? So you need to check a couple of things before you proceed for an IVU.
Yes, sir. First, we have to take the history of any contrast allergy, and then we have to also take the blood investigation. Like we have to see serum creatinine.
Why do you see serum creatinine?
So serum creatinine, because in case of increased serum creatinine, excretion may be low, and there are chances of if GFR is EGFR is low, then there are also chances of contrast allergy. And
contrast allergy with EGFR are not the same things. So why do you estimate a creatinine?
Contrast
induced nephropathy. So these patients are prone for if they have a low GFR, this can cause problems with their contrast-induced nephropathy and it can precipitate renal failure. So what do you do? If you're bound to do a contrast study in these patients and it's a borderline serum creatinine of say 1.5, 1.6, you have to do it. Then what are you supposed to do?
So protective measure, we have to hydrate the patient 12 hours before and 12 hours post procedure. So peri-procedural hydration is the standard treatment. We can also advise him N-acetylcysteine and
Right. So, I mean, these two measures are good enough. So you hydrate the patient very well before the study, and you can add N-acetylcysteine to these patients. You can please continue, Dr. Pathu.
Yeah. So what cutoff do you use? What serum creatinine cutoff do you use to decide whether you would go ahead with the procedure or not?
okay. So we usually use 1.5 milligram per DL of serum creatinine as a cutoff.
So you go just by serum creatinine, or do you calculate something else?
We can also calculate EGFR.
You can also,
it should be
I think you should calculate EGFR. You should not go by serum creatinine. So what formula do you use for calculating EGFR?
we use Crofeld-Gaud formula.
I think we use MDRD formula as far as I know.
Correct. So MDRD formula is the most common one which is used. So Crofeld-Gaud is probably a very cumbersome thing, but yes, MDRD is the most commonest formula used, and
so
these are
there are
calculators available online. You just need to fill details.
Correct. So it's the standard recommendation is using MDRD formula. All other formulas are obsolete. They are no longer used, right?
Yes.
And we follow a cutoff of 30. If the EGFR calculated using MDRD formula is 30 or more, then we can give contrast. Okay, it's safe to give contrast, but if it is less than 30, we avoid giving contrast, right? Then we can go for other modalities like MRI, etc., ultrasound, and all these other modalities which do not use contrast. So we use this MDRD formula and calculate the EGFR. Okay, and one more thing is that so any other history, anything else that you would want to ask the patient before doing this study?
Yes, ma'am. We have asked the patient about history of hypertension and diabetes mellitus and history of medication like metformin.
So why would you want to know the history of diabetes or hypertension?
Because these patients are more predisposed to the contrast-induced nephropathy.
Okay, so if a patient has diabetes, suppose type 2 diabetes, uncontrolled, but the EGFR is 40, will you do the study or not?
Yes, we can do the study, but with the prophylaxis, we can hydrate him well before the procedure.
Okay, so Tarun sir, I think like as per what the latest literature says that there is no role of N-acetylcysteine or hydration. It does not really avoid any kind of.
I know, but these are the questions which the examiners keep on asking since ages, and they expect these kind of answers. The book also carries the same thing. So I agree that metformin, hydration and NAG per se absolutely is found to be useless. Hydration may still be used, but not very effective. I absolutely agree with it.
Right. Yes, for exam purpose, I think theoretically we can say, but practically we do not really follow these. Hydration,
Correct.
yes, but again, we have to really talk to the referring doctor because suppose the patient has fluid overload or edema and all that, we would not like to hydrate the patient even more. And
correct. So these patients with a compromised renal function might eventually land up with a pulmonary edema with overhydration. So
right. So hydration also is with caution. Okay. Anything else for female patients? Any other history that you would like to ask?
Pregnancy, we must rule out pregnancy before doing any X-ray feeds.
Yeah. So you have to ask the LMP also. Right. So diabetes, hypertension, you can ask, but that is not really a contraindication or an indication for the. That is just going to help you in your interpretation or what things you are looking for, but that is not going to be a contraindication, right? So before you do an IVP, you can give a bowel preparation also, right? And you can take the history of any contrast allergy. If there is a contrast allergy, what will you do? Will you not do the study?
If there is history of contrast allergy, we can give him prednisolone 50 mg 12 hours before the procedure. We have to give 3 doses 12 hours, 7 hours, and 1 hour before the procedure. And We have to keep ready the epinephrine. If needed, it can be given after contrast. And
So you give pre-medication and you also change the contrast, right? If suppose the
Yes.
patient has undergone a CT before in the past, right?
Yes.
So you will ask or try to find out what contrast agent was used last time, and you will change the contrast agent.
Yes.
Okay. Okay, so that takes care of allergy and creatinine issues. Okay. Any other questions on this?
Right. So how, what is the position of the patient? Is he standing or is he lying down during an IVP?
So he's standing.
Right. So we can proceed. Yes.
Okay. So if suppose this is the picture on your screen, you see this after maybe a 5-minute film, would you still keep on taking multiple films for 24 hours? So you said that you take multiple films up to 24 hours, right?
In this film, we have not seen the contrast in the bladder. So we have to at least wait for the filling of the bladder.
So do we really need to wait for filling of the bladder? Like, you know the diagnosis here, right? You know what the problem is.
Yes.
You can see the contrast excreted from the kidneys also, right?
Yes.
So, okay, I don't think that we really need to keep exposing the patient to more radiographs just for seeing contrast in the bladder here, right?
Correct.
When if the
You have to
contrast is there.
titrate. You have to titrate according to the diagnosis. So yes, there's no need for doing a 24-hour film in this particular patient, or maybe even a voiding film. Just for the exam sake, yes, voiding films are important if you do not know the diagnosis.
Okay. Okay, we can move on to the next case, sir.
Certainly, yes, please.
Okay, so okay, so a patient has come to your OPD with a suspected renal lesion, and now you want to investigate it. What imaging would you do next? Would you like to do an ultrasound, CT, or an MRI?
This, I will like to do if this was suspected on examination or ultrasonography.
So suppose the patient underwent some ultrasound outside and they
Okay.
said query renal lesion.
Yes. So we will go for CT-KOV provided his serum creatinines are within normal limits.
Provided?
Serum creatinines are within normal limits.
Okay. So again, like serum creatinine, we do not use serum creatinine. So you could probably say provided the EGFR is more than 30 within normal, or it's fine. Okay. So you would like to do a CT-KOB. What does a CT-KOB mean? What is the full form of CT-KOB?
Contrast tomography, kidney ureter bladder film.
Yeah.
It
So
should be contrast enhanced CT.
Right. So what views, what images do you acquire in a CT-KOB? How is it different from a routine CT abdomen?
We have to take the first the non-contrast film. Then we have to take the corticomedullary phase or vascular phase. Then we have to take the nephrogenic phase and then excretory film. So these films are to be needed. And in additional, if we see, plan for partial nephrectomy, we have to also see the angiographic film for the planning surgery.
Okay. Angiographic film for what planning? What do you want to see on the angiographic film?
If we plan for partial nephrectomy, we have to see the additional vessel, any aberrant vessel, and that supply directly the mass.
Okay. So if you have done the CT already and then you are planning a partial nephrectomy, will you again do another CT with an arterial phase? Will you repeat one more scan for your surgical planning? Okay, so you have these three phases on your screen, right? You take a non-contrast and then you give contrast injection and then you take these three phases. The first one here is the corticomedullary phase. This is
Yes.
as good as an arterial phase. So
Yes.
you can see the arterial anatomy very well on this. You do not require another CT angio, right? You can see the aorta very well opacified on this. So the number of renal arteries you can easily make out on this phase. The second one is the nephrographic phase, which is similar to a venous CT, where you can see the IVC and the renal veins very well. So venous anatomy you can see on the nephrographic film, right? Okay, so what do you see here in this set of images?
In the most of the left side of the screen is the non-contrast film, which shows a suspicious lesion in the one lip of the kidney, left side of the kidney. And in contrast film, there is a heterogeneous area of enhancement in the same lesion, so probably suggesting some RCC.
Early washout.
Yes.
Right.
So any other important information that you would like to
Yeah.
like your radiographer to mention?
Yes, sir.
Or
I would
radiologist
like to mention about the enhanced hospital unit, pre-contrast and post-contrast.
Why is it
hospital.
important?
More than plus 20 hospital enhancement is suggestive of RCC.
Okay, so more than 20 is just suggestive of a solid renal mass. It does not suggest an RCC, right? You can have TCCs, RCCs, any other renal lesion with oncocytomas, everything will have more than 20, right? So this 20 cutoff is just to say that there is enhancement, meaning that it is a solid renal lesion, all right? This is just to differentiate between a hemorrhagic cyst or a simple cyst versus a solid lesion, the cutoff, not for RCCs, okay?
Yes.
So can you comment on, so your aim on CT is, one is your detection, that you have detected a renal lesion. Second, we also try to characterize it, right? What kind of renal lesion this can be. So like you said that if the HU, the Hounsfield unit is more than 20, we know that it's a solid enhancing renal lesion. Any further information that you can give, like what kind of lesion this can be, like based on these images? So you see the enhancement on this corticomedullary phase. So this is brightly enhancing, similar to or more than the rest of the renal cortex, right? When you have this kind of a brilliantly enhancing lesion on this phase, then you will think of what kind of RCC?
Clear cell RCC.
Clear cell RCC. What other RCC subtypes are you aware of?
Papillary RCC, chromophobe RCC, and collecting.
Can I say that this could be papillary RCC as well? Can you tell me any one imaging feature that can help differentiate papillary versus clear cell in imaging?
Capillary RCC are generally hypovascular, so it will not enhance so much compared to clear cell RCC.
Right. So papillary RCCs are hypovascular. So they enhance, like you have these renal medulla here, they will enhance like that. The enhancement will be less than that of the surrounding renal cortex. We always assess enhancement on this corticomedullary phase, not on the nephrographic. Like you can see in this example, it kind of washes out a little bit and it becomes iso to the rest of the renal cortex, right? So the purpose of the corticomedullary phase is only to look for hypervascularity. If it is brilliantly enhancing, then we are thinking about a clear cell, right? Any other hypovascular renal tumors you are aware of?
Any type of sarcomas are hypovascular, except hemipericytoma.
Okay, any like more commonly?
Angiomyolipoma is hypervascular.
Sorry?
It is basically less of the fat in the lesion. Angiomyolipoma is usually having more fat, so Hounsfield is less. So that will not be so much of enhancement in angiomyolipoma.
Right. So angiomyolipomas will have fat, right? So fat will not enhance, but enhancing lesions, but hypovascular, other
Oncocytoma.
than RCC. Okay,
Oncocytoma.
oncocytomas show moderate enhancement. Okay. Anything else other than RCCs?
Urotumor of kidney.
Okay, you like urothelial cancers in kidney arising from renal pelvis and the renal calyces, even they enhance less compared to the rest of the renal parenchyma, right? So they can be confused with central RCCs. So centrally located RCC versus TCC, how will you differentiate?
TCC is usually centrally located. There is usually less distortion of the renal parenchyma.
Shape of renal parenchyma is maintained in TCC.
TCC.
TCC may involve the pelvis, and enhancement is less.
Right. Which
Yes.
image will you see to look for involvement of renal pelvis out of the 3 sequences here on the screen?
Excretory film. So nephrogenic.
So the third, right, the third
Yes.
image here, that is the delayed image, right, or the excretory film, and that is the
Yes.
image that you have to see to look for any tumor extension or arising from the renal pelvis, right? It will appear as a filling defect,
Yes.
right? So you have to. That's the importance of looking at this third image. So okay, so here's just an example of a papillary renal neoplasm. You can see how the enhancement of this lesion is similar to the medulla here, right? It does not enhance as brilliantly as the cortex, as opposed to a clear cell RCC. Okay. Tarun sir, do you want to ask any questions here at this point, or maybe we can move on to the next case?
I think we are good. So, do you have any cystic masses?
I have a cystic lesion here.
Yeah,
So I have.
yeah.
Okay.
Perfect. So yes, this is important. Yes.
So anyone would like to take this?
This is a corticomedullary phase.
Now, first of all, you have to say what image you are seeing. This is a contrast enhanced. Or, I mean, you have to tell us what the image is. Don't go to the second step. So what is this?
Coronal cut section of contrast enhanced
Coronal
CT
cut sections. Are these coronal images? What are these images called? These are called axial images, not coronal images.
sorry, axial image
Yeah.
of
Please proceed. Yes.
contrast enhanced CT film.
Okay.
Showing on the right side, the most right film, showing one lesion arising from the kidney, which is non-enhancing, and it's probably a cystic lesion. In the middle of the film, there are heterogeneous areas of enhancement, showing some cystic component and some solid areas of contrast uptake. And the left side of film, it shows heterogeneous contrast enhancement, all probably arising from the renal parenchyma.
Okay. So what do you think these are? What would you like to call them? Just renal cysts, that's it? Or anything would you like to add to that?
On the right side, it seems to be a simple cyst because there seems to be any septation or any calcified areas. In the middle one, we can say it's a type of you can say it's complex cyst, and the left side It seems to be a solid area, so it's probably type more complex. It is more complex cyst having more
So there
enhancing
is
component.
there is nothing like more complex, less complex. So whenever you are dealing with cystic masses, there is a very good classification available.
Yes,
So
so
please
Bosnia-
categorize the cyst as per the classifications.
Yes.
That's what Dr. Patra wants to ask. So less complex, more complex doesn't matter. Give us a classification.
Yes, sir. On the right side seems to be type 1 cyst, and the
Bosnia-
middle one seems to be
So
type
in your
3.
exam, always mention what category, what classification you use. You are using a Bosniak
Bosniak.
classification. So Bosniak type 1 cyst.
Bosniak type 1.
What is a Bosniak? What is the category? I mean, quickly, 1 to 4.
So one is a simple cyst with clear component, clear fluid-like component. 2 is having some septations, and 3 having some septations with
There's one more.
calcified
There's one more between
Sorry,
2 and
2F.
3.
2F
2F,
having
yes.
septations with areas of calcification, and 3 is having some areas of solid component, enhancing solid component. 4 is a complex cyst having almost solid component, almost cyst is almost filled with the solid enhancing areas.
So what is the chances of malignancy in a 2F?
50%.
Cancer malignancy.
Is there any chance of malignancy in 2F?
Yes, sir. It's around 5%.
Sorry?
5%.
5.
18.5%. 18.5%.
18.5% in a 2F.
Yes.
Dr. Patro?
So I think, so first of all, I want to know that what is a 2F? What do you mean by a 2F?
2F is thick
F for
septations
follow.
with a calcification in the septations present. Thick septation, not hairline septa. Second
There
one
is
is
for calcifications. What kind of micro calcifications, coarse
nodular,
calcifications?
nodular calcification.
I think the students will have to read a Bosnia. It is
Exactly.
not so
Yeah,
simple.
it's not so easy.
So there are multiple points in each Bosnia category. You have to be clear with Bosnia 1, 2, 3, 4, and 2F. Where, how many septations, what will be the thickness, whether there's any perceptible enhancement or not, how do you define the solid nodular component, etc. What kind of a margin it has, whether it forms an acute angle with the wall or an obtuse angle. So there are a lot of points, whether there is a hyperdense content, the size of the cyst, then the Hounsfield unit values of the cyst. So I think it will take me some time if I have to explain all those, but I guess the students can read up.
Read. Yeah,
And
certainly.
so for 2F and all, I think there's a big range for the malignant potential for Bosnia 2 cysts. As far as I know, it can range from 5 to 26%, if I'm not wrong. But
So in our literature, it says around, say, 2.5 to around 8 to 2.5 to 10%. I mean, that would be a reasonable range to put up for 2F.
So what would you like to do for the 2F cysts? Would you operate because there is a risk of malignancy, or would you do a follow-up? And what is the interval of, if you want to do a follow-up, what time intervals? So what would you do? And similarly for Bosniak 3 and 4s, what will you do? What is the risk of malignancy for Bosniak 4? If I say Bosniak 4,
Bosnia 4 is 100% malignant.
100% malignant. So Bosniak 4 cyst versus a clear cell RCC, suppose a solid renal neoplasm, right? Why do we have this kind of different, why can't I just say that that is also a clear cell RCC if it has enhancing portions? Is there any difference in the prognosis or any management implications for a renal clear cell solid neoplasm, clear cell RCC versus a Bosniak type 4 cyst, which has got like solid component?
In management protocol, there is no any distinction. Both will have to go for radical nephrectomy, and after histopathological report, we will proceed further if it is a clear cell or if it is something else.
Okay, but the Bosnia type 4 cysts have a much better prognosis, right, compared to the solid
Better.
clear cell
RCC.
RCCs. So to call this lesion as a cyst on the screen, so the first image, for example, you say that this is a cystic lesion, right? To call it a cyst versus solid, how do you differentiate between the two? So you will see the non-contrast and then the contrast, and you measure the HU, right?
Yes.
So the HU, if it is more than less
More
than
than
20,
15,
then you know
more
that
than
it is a
15
cyst.
as
If it is more than 30, then it's definitely a solid enhancing lesion. If it is 20 to 30, that range, it's always indeterminate. And for small renal lesions, we do an MRI to find out if it is truly cystic or if it's enhancing or there's a solid component in the lesion or not, right? And we also follow a visual cutoff of, say, 25%. If suppose there's a solid cystic lesion, so suppose an RCC can have necrotic areas, right? So a solid RCC with necrosis can look like a cystic lesion, isn't it? But we do not use Bosniak classification for a necrotic looking clear cell RCC, right? So we use a visual cutoff of, say, about 25% solid component. If the solid component is more than 25% in the entire lesion, then we do not use Bosniak, right? We call it a solid lesion. If the solid component is more than 25% of the entire lesion. So like if there are some cystic areas, but the cystic areas are less, right? Do you get what I'm trying to say here?
yes.
So for solid cystic lesion, first you have to be sure that whether you want to use a Bosnia classification or not. That's what I'm trying to say. It can still be a solid renal lesion with necrotic areas in the center, right? So you have anything else to ask, or we can move on to the next case?
I think we can move on to the next case.
Okay. So here's the history. This is a female with lower limb edema, and you have the CT images here. What images are provided?
Firstly, we will ask for the USG whole abdomen and pelvis.
That's fine. I mean, we have done with that. We have found a renal tumor. So these are the images projecting on your screen. Can somebody read the scans?
First, this is a non-contrast CT of KUB region showing the right side.
Why? Sorry, I want to interrupt. Why do you say non-contrast?
Yeah, exactly. This is why do you say non-contrast?
There is an aorta.
Can you see the? Yeah. So you will look at the vessels, right? If you want to. You see that the aorta has contrast. You see that the renal vein has contrast, and you can also see that the kidney is also bright, right? So this is a contrast CT. Okay, please go ahead.
Is a contrast CT KOB showing right side renal lesion in the mid-pole region and in the anterior aspect of kidney with left side normal looking kidney, and there is also right side the IVC is dilated, and there is tumor extension into the IVC up to the level of hepatic regions. Intrahepatic IVC thrombus.
Okay, so it's a RCC in the right kidney with thrombosis in the IVC and hepatic and renal veins, right?
Yes.
So is this a tumor thrombus, or do you think this is a non-tumor or a bland thrombus?
So,
It is a tumor thrombus because it is enhancing tumor thrombus.
Yeah, so tumor thrombus will enhance similar to that of the mass. Can you also see some
Yes.
bland thrombus component here on the images?
Yes.
Non-enhancing thrombus. So you can see on the coronal image, right? Just below the level of obstruction. So this is all tumor thrombus in the IVC. And this is all bland thrombus because this is not enhancing, right? Even the left renal vein has non-enhancing thrombus. So
Yes.
what is a better investigation to look for IVC wall invasion? So whether it is just a thrombus in the lumen or whether the IVC
MRI.
wall is infiltrated.
Yeah. Contrast in
RVC wall involvement better delineated in MRI.
Right, better delineated in MRI. That's because we can see the dark wall of the IVC very clearly because of a good soft tissue resolution of MRI. So when this wall of the IVC looks black on MRI, and when that is infiltrated, we do not see that black wall and it gets replaced by tumor signal, we can say that there is IVC wall invasion on MRI, right? But here, like this is frank invasion, so this case we will not need MR, but for indeterminate cases, definitely MR is helpful. So, sir, you want to add something to it?
So what are the levels of thrombus, IVC thrombus that you know of?
Total 4 level of thrombus. First one is into the renal vein only. Second one is from the ostium of renal vein up to the 2 centimeter in the IVC. And third one is from 2 centimeter up to the level of diaphragm. And other one is above the diaphragm.
So thrombus in the renal vein does not encompass into the category of IVC thrombus. So the IVC thrombuses are less than 2 centimeter from the ostia, subhepatic, suprahepatic, and it's beyond that. So renal vein thrombus should not be categorized into the categorizations of IVC thrombuses. And what are the implications of having a tumor thrombus versus a bland thrombus? Does your treatment vary? If you have a bland thrombus versus you have a tumor thrombus, does your treatment vary?
If it is tumor thrombus, there are chances of invasion of the wall. So we have to already plan for IVC resection and grafting. So we have to take for the we may need the help of CTVS surgeon.
Right. What do you do about the bland thrombus? How do you take it out?
Blank thrombus is can be extracted with the forceps.
So you need not touch the bland thrombus at all. That's the answer. You need not extract the bland thrombus. Bland thrombus can be left intact. There is no need for, you just need to isolate the IVC. So you need not take it out. What is actually a bland thrombus?
Bland thrombus is necrotic areas, necrotic part of the tumor, which which has no vascularity.
Bland thrombus is just a coagulum. It is not a tumor tissue. It's a coagulum. So this coagulum or a clot can be left intact inside the IVC. You need not extract this out at all. And the reason for not extracting it out, that because of the blockage, the collaterals have already developed, so you need not touch it. But tumor thrombus, because it's a tumor entity, it has to be taken out. Right, we can proceed now.
Okay, this case, who wants to take? Can you spot the abnormality?
Dr. Sachin is there, right? Sachin?
Yes, yes, sir.
Can you make yourselves visible?
Yes.
Right, so can you just take this question?
Sir, it is a contrast enhanced CT KUV and showing corticomedullary phase, sir. And it is showing, sir, some filling defect on the left side of pelvis, sir. Left side
No,
in
no. Why are
pelvis.
you commenting upon a filling defect on a corticomedullary phase?
You are describing the first image, but you are interpreting the second image.
Second
Correct.
one is expiratory, sir. Second one is expiratory phase. First one is corticomedullary.
Right. So do not use a filling defect in a corticomedullary phase or a nephrogram
Yes,
phase.
sir.
Filling defect will be in the
Yes, sir.
expiratory phase.
Yes, sir. First one is corticomedullary. Second one is expiratory.
So what is your tentative diagnosis?
Tentative diagnosis is, sir, UTUC, sir, upper tract urothelial carcinoma. We will have to look for the other images also to look for the extension into the ureter and the bladder, sir. For concomitant bladder carcinoma, TCC, and also in the extension to the ureter.
Right. So this is the importance of doing a delayed phase, right? So that we can appreciate the extension of the tumor along the renal pelvis and the ureter. When we see this kind of a urothelial carcinoma involving the renal pelvis and the renal calyces, we look at the ureters very carefully. Opposite kidney, the opposite renal pelvis and the calyces, the both ureters and the bladder. We look at all these areas very carefully to look for any synchronous lesions, right?
Yes.
Okay. So anything, sir, you want to add to this?
But
Okay, so just another example to show the filling defect. So very important to look at the delayed images, right? Okay, so just an ultrasound picture. We've already discussed the renal lesions. So what is this, the third image? What is this in the kidney?
Yes, it seems to be anechoic area, which is well marginated. So probably renal cyst.
Okay, what Bosnia category would you like to give this?
Type 1 Bosnia.
Okay, so Bosnia category is used purely on CT and MRI. It is never to be used on ultrasound, right? So if you see this kind of a cyst on ultrasound, you just describe it and that's it. Leave it at that. You do not add a Bosnia category to it. Okay,
Yes.
so this is just to mention that. So you could say a simple cyst, or you could just say a cyst without any internal septations, no solid component, no calcification. You could just mention the negative points, but you can mention it as a simple cyst on ultrasound and leave it at that, right?
any modifications
Okay.
of an ultrasound that you know of, if you have a septated cyst, you cannot give contrast to this patient for some reason. Now, any modification of an ultrasound or any addition on an ultrasound which can tell you whether this is these septae are suggestive. I mean, there might be neoplastic lesion.
These are contrast
Contrast
enhanced ultrasonography.
How
So
does that
you,
help?
SF6 we use, sir.
Sorry?
SF6.
So yes, I mean, you should know about contrast enhanced ultrasound. So we inject microbubbles and then these septas might show uptake, and you can suspect them of being malignant rather than benign. Right.
So they will show an early enhancement, any kind of a solid component. So suppose there is a hemorrhagic cyst. If the clotted content can also look like solid component, right? So if you want to differentiate between a organized hemorrhagic content versus a solid content, or if you want to look for vascularity in the septations, then you can do a contrast enhanced ultrasound, and all the suspicious areas will light up earlier compared to the rest of the normal kidney, right? And the anechoic fluid, the simple clear fluid will not pick up any contrast. Okay, so suppose if you have a serum creatinine of 2 and you have a 30-year-old male with a suspected renal lesion, what investigation would you do next? We've kind of discussed this before, but just for a recap.
MRI kidney.
First, we have to calculate EGFR at this serum creatinine 2, and if EGFR is more than 30, we would go for MRI.
Correct.
MRI
So you do not.
for contrast enhanced MRI, if we are using gadolinium, then only we want EGFR. No, if we are doing plain MRI, then
No
we don't
contrast
need
is involved.
Sorry, will you give contrast on MRI or not?
Contrast is needed for in contrast enhanced MRI. We would better delineate the lesion.
Okay, so serum creatinine is 2. Okay.
Yes.
What you will do next is you will calculate the EGFR, right? You can use this calculator online and you calculate it. If it comes to more than 30, so for example, in this case, the EGFR was around 42, it was coming to 42, which means that you can safely give contrast and you will do a contrast CT KOB, right? You will not do an MRI kidney. But suppose if this EGFR was less than 30, say about 28, right? Or less, any other value less than 30, then there's no point of doing a non-contrast CT KOB. That is not going to give us any information. What you need to do then is do an MRI kidneys. And this formula is applicable to both CT and MRI contrast. So it is not that if the CT contrast can't be given, you give MRI contrast, right? It's applicable equally to both. So if the EGFR is less than 30, we avoid giving MRI contrast and CT contrast both. So you will do a non-contrast MRI kidneys, right? So we have like very good sequences on MRI. We have very good T1, T2 diffusion and other image sequences like SWI and all that. And they give very good information about whether the renal lesion is a solid lesion versus a cystic lesion. We may not be able to differentiate the various subtypes, but to a good extent, a non-contrast MRI can differentiate between papillaries, TCCs versus clear cell RCCs based on the non-contrast MRI images. So if your EGFR is less than 30, you can safely go for a non-contrast MRI kidney. Okay. Okay, so you have various role of MRI. I'm just enlisting a few of them. If the CT is contraindicated because of contrast issues, if you have small renal lesions like renal lesions less than 2 centimeter, CT is not very good because you may have a false pseudo enhancement on CT. So to really differentiate between a solid lesion versus cystic lesion, this is very good. And the different subtypes of RCC, IVC invasion, and also when you have done a procedure, partial nephrectomy or a ablation, you are going to follow up the patient multiple times, then you can avoid a radiation exposure and you can just do a MRI for those patients. So we move on to.
We can also use in pregnant ladies. If lady is pregnant, then we should avoid the CT.
Yes, in third trimester we still can. We should better to avoid it in the first 2 trimesters. So definitely not CT. If we have to, but then we have to take into account the risk versus benefit, right? In a pregnant lady, if renal lesion evaluation, I don't think that is going to be an emergency. We have to basically think about.
Actually, angiomyolipoma is precipitated during the pregnancy because of the effect of progesterone. And if she is having the hemorrhage, then we will have to look for it. If she is having AML,
you could do an ultrasound in that case. Ultrasound is also good enough in picking up fat containing lesions in kidneys, right? And if the patient is bleeding from the angiomyolipoma, you can pick up hemorrhage also very well on ultrasound. So you can still avoid a CT and an MRI in that situation, right? Okay, so we have time. Like, should we move on to?
Yeah, certainly. Please proceed.
Or do we want to keep the nuclear medicine lecture in between, or?
No, you can continue, and then once you finish up, we will go for the nuclear medicine.
Okay, so this one is now next case. PSA was 15 and on digital rectal examination, nodular prostate, nodular hard prostate. And now you want to investigate further. You want to see if there is any malignancy in the prostate or not. What imaging would you do next?
MP-MRI.
Right. So you will do an MP. What is the full form of MP?
Multiparametric MRI.
Sorry, something got mixed up. Okay. So here are the images, the MRI images for this patient on the screen. Can you identify the sequences? Okay, so what is this? The first one?
First one is T2 lesion.
Mm-hmm. Right. So what do you see here? This is a T2 sequence, and these, the second and the third are called diffusion weighted imaging. There are two sequences, two components of diffusion weighted image. This one is a ADC, apparent diffusion coefficient, we call it. And this one is a DWI, so diffusion weighted image, basically. A DWI plus ADC together is called diffusion weighted imaging. And we always read these two together, right? They are never read in isolation. Can you pick up any abnormality here in the prostate? So this is the prostate, right? This is the transition zone in the center and the peripheral zone.
This is the right side peripheral zone. There is a lesion which looks black in this.
Okay.
Also in the anterior aspect.
Sorry?
There are hypointense areas in the peripheral zone, which corresponds to the diffusion weighted image, where there are also restriction of diffusion.
Okay.
Showing peripheral zone tumor.
Okay, so the right peripheral zone tumor. Would you like to have any other sequences for this? So what is multiparametric? What are the different parameters in multiparametric MRI?
T2W, DWI, which include ADC also.
Mm-hmm. And is this multiparametric, the three images on the screen?
Yes, ma'am.
Or is there any other parameter?
Also constitute DC, dynamic contrast in them.
And diffusion weighted DWI. T2W, DC, and DWI.
Right. So multiparametric is a combination of three sequences. You have a T2, which is for the anatomy, right? And these two are your diffusion weighted image. And then you give contrast. And then you do multiple phases, right? Post-contrast images, which are called dynamic contrast enhanced. So a combination of these three is called dynamic. We do not do multiparametric for all patients. Most commonly, what we do is a biparametric, which is T2 plus diffusion, right? If we have an obvious PIRADS 4 or a 5 lesion, which is clearly looking suspicious and has to be biopsied, we do not give contrast. So we do not do a dynamic contrast phase, and just a biparametric is enough. If there are any indeterminate lesions like a PIRADS 3 lesion, we do not know, or there is nobody to monitor the scans when the scans are happening to decide whether contrast should be given or not, only then we give contrast. Otherwise, not in all cases. So this one is a PIRADS 5 lesion in the right peripheral zone. Any role of spectroscopy? You might be seeing this image also, like when patients come to you with outside films or at your centers, you might be familiar with this kind of a graph-like thing. This is a MR spectroscopy. Does this also come in? Is this also included in the multiparametric MRI?
It can be included or it cannot be. Plus minus.
It can be means. So you will do this. Will you require this or not?
No,
can
not
be
always. Not required.
Not required. So this has basically no role in detection or characterization of prostate lesions. It used to be done 5 years ago, but now it has been found to add no value to your image interpretation, right? So we do not perform spectroscopy. We do get requests, I mean, like scans done outside, and then we get the CDs uploaded here. We find this sequence still being taken at many centers, but it has no role, right? So multiparametric does not include a spectroscopy. So, sir, shall we go into any basics of PIRADS, or
I think PIRADS they can read. PIRADS they can read, and the important part is that you should know about the percentages of tumors in PIRADS. So PIRADS 1 doesn't mean that absolutely cancer is being ruled out. So you just need to know about the percentages. The detailed interpretation may not be required for the urological students.
Right. So PIRADS 5, if I say something is PIRADS 5, the maximum positive predictive value can be about 70 to 75%, which means that if I say that a lesion is PIRADS 5, I can still be wrong in about 30% of cases, right? But the strength of PIRADS is in calling something a PIRADS 1 and 2, which means that biopsy should not be done. Like PIRADS 1 and 2, no biopsy. 4 and 5, definitely biopsy. And 3, biopsy in certain situations, right? We have to take into account the other risk factors and then decide whether biopsy has to be done or that patient can still be kept in follow-up or not. So for pyrites 4 and 5, it is about 50 to 75% is the positive predictive value. For 1 and 2, it is about 6%, right? And for pyrites 3, it's about 30% is the positive predictive value. Okay. So when I say that the lesion is pyrites 1, I am like 94% times I'm going to be correct that there is no cancer in that prostate. Even if it is there, it would be most likely to be a clinically insignificant cancer, right? So it's 6% is the positive predictive value in pyrites 1 and 2. Okay. But in pyrites 5, it is maximum up to 75%. It's still not 100% accurate, which means that we have to biopsy and it can still turn out to be a negative biopsy, right? But the aim of pyrites, creating pyrites, is just to avoid unnecessary biopsies. So if we say pyrites 1 and 2, don't do biopsy, but 3, 4, 5 can go for biopsy. 4 and 5 definitely biopsy, and 3 also biopsy in most situations, right? So we can move on to the next case, sir.
Certainly, yes.
Okay, so what do you see here? This is another example of a prostate. We have this T2 image, and this is the diffusion and ADC. So typically prostate cancers will look black on T2, right? What do you see here? Can you see this thing? So what is the signal or what is the color of this area? This is the abnormality in the prostate, the right side peripheral zone.
This is iso-intense.
ISO intense to what? So when you say ISO intense, it has to be compared to something. ISO to what?
Normal parenchyma.
Okay, so this is the normal parenchyma. You can see how black this is, or I should say
Yes.
probably grayish intermediate signal. This is the normal prostatic parenchyma, and this clearly looks hyper intense compared to this parenchyma, right? Can you see all this white material inside?
Yes, ma'am. Yes, ma'am.
So what do you think is this? Cancers will be dark typically, unless
Dark.
in some rare situations you have mucinous variety of prostate adenocarcinoma and all. But what do you think is this hyper intense thing in the right side peripheral zone? You also have some other
Cyst or
images. Sorry.
So prostatic
this is
cysts
all-
will be more regular. I mean, this is a very irregular lesion, hyper intense. You have the other sequences also supporting the evidence that it's a very clear-cut diagnosis.
So there is diffusion restriction inside it, right? It looks very bright on the
Prostatic
diffusion
abscess.
image.
Correct.
Prostatic abscess.
Right. So prostatic abscess. So you can also take the history of fever. You might have your clinical examination can also give you clues. But on MRI, typically abscesses will look bright, which is just the opposite of how cancers look. Okay. So and diffusion, they will restrict. Diffusion will restrict in both cancers as well as prostatic abscesses, but it is the T2 signal that will help you in differentiating. Okay. So if you have this kind of a bright T2 signal, you will think about prostatic abscess. Cysts, like as I said, they will be very small, regular, and they will not show any restriction because they have like clear fluid inside them, right? They will only show restriction when there is something filling up the lesion, right? Be it malignant cells, be it pus or anything. Whenever there is something filling up and causing tightly packed cells, that is when you show this, when you see this kind of diffusion restriction. So cysts will not show diffusion restriction, right? And if you have to drain it, then what modality will you use? Will you do MR guided drainage? You have seen this, picked up this abscess in the prostate on MRI. So
We
now
can
you want to
go
drain
for transurethral delooping of the prostatic capsule.
transurethral. Sorry.
Delooping of the prostatic capsule.
Sorry, I didn't
Drainage
get
of
what.
the
So yeah, I mean, he's correct. So in the surgical parlance, we'll have to do a deroofing through the urethral route. So yeah. So, but
Okay.
there are multiple other modalities also available to deal this thing. But in the examination, I think so the student should stay away from saying that we are going to do a per rectal drainage. I think that's something not to be used during examination. So the answer with these urologists will stick on to is probably transurethral drainage of the abscess.
Okay, got it. Okay, so okay, now you have a bladder mass detected on cystoscopy. What imaging would you do?
CT whole abdomen plus thorax.
Okay, so CT KOB or whole abdomen? Whole abdomen
Whole
does not have a delayed image. Okay, whole abdomen is always just a non-contrast and a venous phase. A CT KOB is kidney urinary bladder,
Yeah.
so that includes contrast and a delayed, right? Why
Okay.
you would like to do thorax?
To rule out the metastasis.
Okay, so here's an ultrasound image. Ultrasound is just going to pick up some kind of a lesion, right? You cannot really differentiate most of the times between a mass versus a clot or a combination of both. And also ultrasound is not good enough for assessment of the invasion of the muscle layer, right? So, and you also need to evaluate the upper urinary tract. So ultrasound is not the best modality. You have to do a CT KOB. So what do you see here?
I'll just interject. Can you just go back to the previous image? So now you have an ultrasound. Tell me again a standard exam question. Tell me how would you differentiate between a mass versus a clot on an ultrasound?
If it is a mass, then there will be vascularity in the Doppler, and also
Okay.
with movement, lesion will not move. And if it is a clot, it will move with the movement.
Correct.
And no
Correct.
vascularity will be there.
Correct. Right.
Right. Okay. So you will do a CT, right? But beyond that, you can't really get much information from ultrasound, right? You can try to differentiate between a clot versus a mass, but that's it. And you also can assess involvement of orifice or any hydroureter nephrosis on ultrasound, right? But if you have to do a baseline workup of the patient to decide further management, you have to do a CT KOB, right? So what do you see here?
This is a non-contrast along with the contrast enhanced CT film with extremity film. So in non-contrast film, there's is a tumor on the right lateral wall, and which takes enhancement on the enhancement of the contrast is well opacified, and in extremity film there are filling defect which suggests it as a bladder tumor. And since irregular thickening of the bladder wall can also be noted, there do not seems to be any enlarged lymph node in this area.
Okay, so you see a growth along the right lateral wall of urinary bladder, right? So
Yes.
if I ask you the local stage, what would you say?
It seems to be muscle invasive bladder tumor.
Okay, how do you say this is muscle invasive?
Because
Can you
the
identify the muscle layer?
Yes, ma'am. The contrast enhancement of the tumor is almost as enhancing on the right lateral, as the right lateral wall of the bladder is also enhancing as to the same extent as the tumor. So it seems to be in a muscle invasive.
So the enhancement of the urinary bladder wall in the non-involved portion is same as that of the enhancement of the tumor. So how do you differentiate between a tumor here versus just bladder wall thickening similar to the rest of the bladder? Can you
Usually,
differentiate? Yeah, sorry.
when it is involved with the tumor, it is usually irregular thickening, asymmetrical thickening of the wall.
Okay. So the thing is that on CT, we do not comment on the local stage. CT is not the best modality to say whether it is T1, T2, T3, T4. Yes, if we see obvious tumor outside the bladder, going outside into the perivesical region, then we can definitely say that it could be a T4. But T1, T2s and T3, we do not really comment on CT because the enhancement of the bladder wall, a normal uninvolved bladder wall, can be same as that of the tumor. So we cannot really differentiate between the two over here, right? We can't say this is tumor or this is purely just bladder wall. So how do you differentiate? Do you go for histopath, or do you have any other imaging modality also that can help comment on muscle invasiveness?
Although MRI can comment on the muscle invasiveness, but better pathology will be, tell the best staging will be done by the pathologist.
Okay.
MRI but can comment on the muscle invasiveness.
So, Tarun sir, I think TURBT is done, but then it's not always 100% accurate in
Yeah, I mean,
commenting on the.
yeah. So TURBT is if a good TURBT will be accurate, but I mean, we cannot. So if you need an imaging and you want to have a good assessment of the muscle invasion prior to doing a biopsy, I think the answer is an MRI, and that's why the question was. So what's that? So if you have pyrids in prostate, there is something in the bladders also, which can tell us whether it's a muscle invasive or not.
Virus.
So what is that?
Pirates.
Can somebody tell me what
Virus.
what is the full form of pyrids and what is the full form of virids?
Prostate imaging reporting data system.
Perfect.
Just like a vesicle imaging reporting and data system.
Right. What is the version of
Imaging
pyrids
reporting
which we are
data.
using these days?
2.1.
Wonderful.
V2. Pirates V2.
Right. So I think you guys can read up on virids. It's just a likelihood score ranging from 1 to 5 for muscle invasion, right? Present or absent, right? So this is just to show you that on MRI, you can appreciate the difference in the signal of the wall and the tumor, right? You can see the interface, and you can see that the tumor signal is clearly different from the bladder wall, the normal muscle layer of the bladder. But on CT, you can't differentiate between the two, right? So you do not know what is happening over here unless you see an obvious tumor which is popping out of the bladder wall. So I think, sir, I can skip the virids portion.
Yes. I think they can read for themselves, certainly.
Okay, so you have an adrenal lesion now. There's a suspicion of an adrenal lesion. You want to know whether it's a adenoma, it's a benign, malignant lesion. You want to characterize it. Something suppose picked up on an ultrasound. What imaging would you do next?
CT abdomen and pelvis with adrenal protocol.
Okay, so what is the adrenal protocol?
If there is, we will have to look for unenhanced image and enhanced image, and we will also look for the delayed enhancement. And then we will have to look for the washout, and after that we can calculate the relative washout and absolute washout. If relative washout is more than 40 and absolute washout is more than 60, then it will be a adenoma, suspected adenoma. And if it is delayed washout and delayed contrast uptake, then it is most likely a malignant lesion.
Right. Okay. So you do an adrenal protocol. So you have to tell your technician to do a CT with an adrenal protocol. Otherwise, they will not take a delayed film, which is acquired at a 15-minute interval, right? We do not take a 5-minute or a 10-minute delayed, unlike bladder, liver lesions, etc. So it has to be a 15-minute for calculations. So we do a plain scan first. So do you know any Hounsfield unit cutoff to call it an adenoma, a fat-rich adenoma on CT?
At least is less than 10 Hounsfield.
Less than 10.
Right. So if you have a Hounsfield on plain scan less than 10, you do not need to give contrast. Also, you can avoid giving contrast, and you do not have to go into that absolute or relative washout calculations, right? If it is less than 10, you are sure that it is a fat-rich adenoma, and you just stop at that, right? But if the Hounsfield unit is more than 10, that is when you need the contrast and you do the calculations. And like you just said, that if you have these percentages, then we think of a adenoma, right? Both fat-rich and fat-poor adenomas. This is applicable to both kinds of adenomas. So CT, the purpose of imaging is to characterize the adrenal nodule as an adenoma versus rest, right? We can't really differentiate between all the types of adrenal lesions. There are certain certain adrenal lesions which have typical imaging appearance, but most of the time the aim of imaging is to differentiate between adenoma versus all others, meaning indeterminate lesions, right? So any role of MRI here? Would you need to do an MRI for an adrenal lesion? So you are calculating the
Pheochromocytoma
what?
can delineate in the
Sorry.
T2 weighted image, light bulb sign. Pheochromocytoma can be picked up in the T2 weighted image of MRI clearly, as it is shows a light bulb sign.
Okay. So CT is not going to help for pheochromocytoma. Is that what you're saying?
It is equally good for pheochromocytoma.
Right. So everything for all adrenal lesions, we do a CT, and just a CT with adrenal protocol, that is enough. If some lesion is not getting characterized on CT, we have to biopsy it. But the role of MRI is only for the detection of fat poor adenomas. That's all. Other than that, I mean, MRI does not help for detection or characterization for any adrenal lesion. So we have some kind of images on MRI, which is called the chemical shift image, where the adenoma shows this kind of a loss of signal. If you see here, it's looking bright, and then it suddenly shows a drop in signal in the chemical shift image. That is very typical for an adrenal adenoma. So MRI is only useful for this. If the Hounsfield unit is more than 10 and we are not able to characterize on CT, we can do MRI to pick up a adenoma, a fat poor adenoma. Other than that, for rest of the adrenal lesions, it is not going to be helpful. Like if you want to differentiate between METs versus pheo versus any other kind of adrenal lesion, then we have to just stick to CT or go ahead with a biopsy, right? So what kind of a lesion is this? You have a contrast CT available and incidentally picked up adrenal lesion. The scan was done for some other indication. So I'm just showing you some typical
adenoma. It seems to be adrenal adenoma because there's poor contrast enhancement and which is well marginated.
Okay, which side? Is it right or left? So you start with what image you have been provided, right? You mentioned that you have an axial contrast enhanced CT image, right? You start with that. And then you say that there is a adrenal lesion left on the left side.
Yes.
Right. Then you start mentioning the other features of the lesion.
This is the left adrenal adenoma.
Okay, so why is this an adenoma?
Because it's non-enhancing and well encapsulated.
Okay. Would you want to know the HU Hounsfield unit value for this lesion?
Yes, ma'am. We would like to know the Hounsfield unit.
Okay, so the Hounsfield unit was minus 100.
Lipid content.
Minus.
So minus 100 means it contains fat, macroscopic fat, right?
Yes.
Yes.
So what would be your differential then? Macroscopic fat containing, bulk fat containing adrenal lesion.
Adenolipoma.
Sorry? Myelolipoma. So you see the abdominal fat, how black this is the subcutaneous fat. You see how black this is. When you have an adrenal nodule which contains fat, which has got the similar density compared to the fat, rest of the fat, then you have only one diagnosis. This is a spotter image, right? This is an adrenal myelolipoma. Adenomas do not contain macroscopic fat. They never look black like this. Okay. So you want to add something here?
No, nothing. I mean, this is a very classical image of an adrenal myelolipoma.
Yeah.
There is no doubt about it. But yes, the student should describe an image rather than just shooting for the answers. I mean, there's an adrenal lesion, so you have to tell it this is a axial cut of a contrast enhanced image of a CT scan, and we are able to see a lesion involving the left adrenal, as Dr. Patro has said. And this classically has macroscopic fat. Macroscopic fat in adrenal, the first diagnosis, maybe the only diagnosis that comes to your mind is myelolipoma. So there is no doubt about it. And possibly for this lesion, you do not need any other sequences. This is a sufficient image.
Right. So you should just remember this appearance, and you should not start thinking of adenomas and other kind of lesions. A very, very typical spotter, and you just have to put it in your visual memory. Okay. So next case, again, describe the image provided.
Again, a very classical spotter. I mean, there is no doubt about the diagnosis. Just describe the image, we'll know the answer.
This is axial cut section of CT showing corticomedullary phase, and there are the left renal vein having heterogeneous areas of a circumscribed mass having heterogeneous areas of enhancement.
Okay, so this is actually not renal vein. This is at a higher level. So it's actually a suprarenal lesion. Okay, let me just tell you, I should have added a coronal image also here, I think. Okay, so it's a suprarenal lesion, what you're describing.
Okay. So
Go ahead.
showing a heterogeneous enhancing solid
A
lesion.
solid, heterogeneously enhancing, very brightly enhancing lesion in the suprarenal area. Somebody just used the term around 5 minutes back. So what is this sign called as?
Light bulb sign.
Yeah, so somebody just mentioned light bulb sign.
MRI is the that we use.
Sorry.
So light bulb is on CT scan also. So any kind of, so it enhances, it takes up the contrast so brightly that this is called a light bulb sign. This is just not an MRI, but this is a CT finding.
Yeah, so it looks as bright as a enhancing kidney. Like if you compare it with the kidney, the cortex of the kidney, it will look as bright as that, right? So something in the adrenal which enhances brilliantly, you have to think of, I mean, you have to say pheochromocytoma, right? And this is true for MRI also. If you do an MRI on T2 of MRI also, it shines very brightly. If you give contrast on MRI, then also it picks up contrast and it looks like brightly enhancing, right? That's why it has the name of light bulb sign. Okay, so this is a pheochromocytoma. Okay. Okay, so next case. So please let me know if you want me to stop at some point of time.
Maybe another 5 minutes. You can discuss
Yeah,
this
sure,
case
sure.
and then we
Okay.
move on.
Yeah, sure.
So I think this is an important topic. So very neglected one. Suspected penile growth. What investigations to order after local evaluation?
Clinical examination is sufficient.
Clinical examination is sufficient.
So if you find that the growth is big, it looks like a T3 lesion to you, would you stage the disease with some investigation? What is the guideline recommendation for a penile cancer?
CT abdomen and pelvis.
Does MRI have any role in the management of penile cancers?
Having the role if in suspect glass lesion, if it is T2 lesion or T1 lesion, then
100%
better delineated on MRI.
100% sensitivity for corpora spongios cavernosum involvement.
Local staging.
Right. So how do you do this MRI?
Normal T1, T2 images can be done, and sir, we can also do diffusion weighted imaging, in which restricted movement can also show about the penile lesion and also about the inguinal lymph nodes.
So how do you keep the penis during the scanning?
Erected, sir.
Yeah, I mean, yeah, stretched can be done. I mean, erection would be a very difficult thing to have during the MRI, but yes, it has to be stretched. Dr. Patra, please proceed.
Yeah. So we do MRI for local staging, right? And also for metastatic workup, you have to do a CT thorax and upper abdomen, right? But there is no role of doing a CT pelvis or a CT penis, right? That is not going to give you much information. Here I'm showing you a CT image. You can't really appreciate the different parts of the penis on CT. Everything looks like same, homogeneous. But if you look at the MR image, because of the excellent resolution of MRI, you can make out the tunica, the corpora spongiosum, the cavernosum, and all the other adjacent structures very nicely on MRI. So for evaluation of penis, you have to do an MRI pelvis only. There is no role of doing a CT pelvis. CT is only for metastatic workup of thorax and upper abdomen, right? So these are the corpora cavern. Sorry, the screen moving. So this is the spongiosum, this is the cavernosum, and you can see the urethra here, and then this is the tunica tunica all around it. So I have another case. So this one. So here there is a lesion. Sorry, my screen is jumping. Okay. So anyone wants to describe the lesion here? So who wants to take this? What is the abnormality here? This is an MRI image, MRI for the penis, and I have an axial image and I have a coronal image. These are T2 images. Any abnormality? And what stage would you assign this? So what is this over here? Do you think this is normal or is this a growth?
This is a growth.
Okay. So like I just said that this is the corpora. What is this? The paired structures.
Corporal cylinders.
So this is, yes, cavernosum. So this is the lesion over here. You can clearly see that this is disrupting the black line all around it. So I mean, like this is the normal corpora cavernosum, and over here the tumor has infiltrated it, right? So what stage would this be? I think, sir, I don't have to really talk about the staging and all that. That I think is
they know about these
they can
staging. So
read,
corpora
they can read.
cavernosal invasion. Yeah, correct.
Yeah. So this is just to show the invasion, how the normal anatomy of penis looks brilliant, like very nicely seen on MRI. So just to show an example, and you should not say CT whole abdomen for local staging of penile cancers, right? So other than the local evaluation of penis, like just other than the penis, we also look at what? We look at the lymph nodes, right? So what lymph nodes do we look at? Inguinal. Yeah, inguinal and the pelvic lymph nodes.
Pelvic lymph nodes, correct.
Right. We also evaluate the extracapsular extension, right? That is also included in the staging. So you can see here there's one big necrotic nodal mass in the right inguinal region. It has got very infiltrative margins, matted appearance. So this is a typical case of an inguinal nodal mass with extracapsular spread. So when you are reading a MRI penis, you have to look at the local T staging, and you also look at the nodes, the inguinal lymph nodes, external iliac lymph nodes, common iliac lymph nodes. Okay. So, so you have any questions here?
Madam, may I ask you a question? I'm Dr. De. So what is the recommendation of the MRI in assessment of the inguinal region?
So recommendation means the sequences that we do?
No, sir, ma'am. I'm asking at which size of the lymph node we are expected to get a positive suggestive MRI finding.
Okay. So the cutoff, actually it is, we do not follow a strict cutoff. Usually our textbooks say that a size cutoff, a short axis dimension of lymph node more than 8 millimeter is suspicious for involvement. But even lymph nodes which are smaller than that, if the lymph nodes have got some kind of a abnormal morphology, for example, if the nodes are rounded, or if the signal intensity of the nodes are intermediate signal, which is similar to that of the tumor, or if they have got some irregular, indistinct margins around them. So basically the morphology of the nodes is equally important, and we just do not go by the size criteria, which is true for any pelvic lymph nodes, be it inguinal or any lymph node of the body. It is not just the size criteria, but also the shape, the signal, and the morphology characteristics.
Thank you, ma'am. Thank you.
So can you just tell them what is SAD? SAD is at times mentioned in the reports and people do not know that. So size criteria, what is SAD?
Yeah. So for oval lymph nodes, SAD is only applicable for oval shaped lymph nodes, not for round, because for round lymph nodes, all the dimensions are going to be similar. So when you have an oval lymph node, you have got a long axis and you have a short axis. SAD means short axis diameter and LAD means long axis diameter. When we measure the size of the lymph nodes in our reports, we use only the SAD or the short axis diameter. That is what is followed by in RECIST guidelines, right? So we take, so I don't know if you can see my mouse over here, or I can use this annotation. Can you see this line?
Yes.
On the screen? So this will be the short axis diameter of this particular lymph node. So here's an oval shaped lymph node, and this is what we measure. And then we report this as millimeter or centimeter or whatever. So when we say that lymph nodes are pathological in the pelvis or in the inguinal region, we usually take a cutoff of 8 millimeter, but we just do not purely go by the size criteria. Size, we also look at how suspicious their appearance is otherwise. So when these nodes start becoming rounded, for example, here we have the left-sided inguinal lymph node, which is round, right? When the nodes become round, we call them suspicious, because oval is how the shape of normal lymph nodes is like. They have fatty hilum and they are oval shaped. And also when there's a morphology abnormality, for example, this lymph node has got necrosis in the center. All the bright thing in the center is necrosis. So the moment we start seeing necrosis, even if it is a 5 millimeter lymph node in a squamous cell carcinoma, there is central necrosis, we will definitely call it pathological lymph node. So this is how we measure the SAD or the short axis dimension.
Great. I think I'm very thankful to Dr. Anurima for such a detailed and elaborate discussion. I think the students also fared very well. They were able to answer majority of the questions. But yes, the descriptions of the images have to be more pertinent. You have to be very to the point about whenever you are describing any kind of image. I think beyond that, the students did very well. So thank you so much, Dr. Patro. And can I now invite Dr. Puneet Sharma? He's a consultant of nuclear medicine at Apollo Gleneagles Hospital, and I would please request him to discuss about the DMSA and the DTPA scans. Hi, Dr. Puneet. Thank you for joining us.
Hi, Dr. Tarun. Thank you for inviting me. So what I will do is I will just give a brief overview, and then we'll move to maybe any further questions we have. So what happens is we are most familiar with the radiological imaging techniques, but our knowledge in general, because the exposure is a bit limited, for nuclear scintigraphy is a bit limited. So what basically nuclear scintigraphy or nuclear imaging is we tag a radionuclide, a radioactive atom with a compound, a pharmaceutical, and we get a radiopharmaceutical, which is then injected, or whatever way of administration is, we administer into the patient that targets a specific organ, and when we get the image. So basically it's a functional imaging as compared to radiology, where mostly it is anatomical, obviously functional. So for renal imaging, what are the targets we have? What things with the perfusion, which is very important in case of transplant evaluation. There are different compounds for that. We can target the glomerular filtration, either in vivo method, which is done with technetium DTPA, or in vitro method, which is more reliable but less commonly available. Then we can target the renal function or tubular function. The tubular function can be targeted for tubular secretion with the normal MAG3, EC and all, or tubular fixation with DMSA. Then we target the excretion, the excretory pathway and how it is functioning. That can be targeted with a D2PA, MAG3 or EC. And then in some cases, we can also assess the psychoureteric reflex. Now coming to renal dynamic scan or renal dynamic scintigraphy, which is most widely prescribed or used. What we are doing is we are injecting a radio tracer, and we are monitoring the transit of the tracer through the kidney and the excretory pathway. So that's why it is called a dynamic. So we are taking a dynamic follow-up of the tracer. So what are the compounds we have for that? So we have a technetium DTPA. Normally it is prescribed as DTPA scan, but that is not really true. While technetium DTPA is most widely used and most widely available, one of the major reasons for it is it also gives you an estimate of GFR. So with the same method, you can have a, GFR estimate, and you can also see the renal function and excretion. But there are some problems with using DTPA. For example, the extraction fraction of DTPA is lower, so the background activity is high. So if the patient has a impaired renal function, DTPA scan is not that great. So for that, we have alternatives such as technetium EC, which is widely available in India, or MAC3, which is available in very few centers. But in our literature, we mostly read about MAC3 and all, which is mostly done in Western countries. In EC or MAC3, we don't get the GFR, but we get the effective renal plasma flow. And from that, we can get an estimate of GFR by dividing it with 3.5. The advantage of EC or MAC3 is that the background is lower. So even patient with impaired renal function, we get high quality image. So if our target is mainly renal function and excretion, but not GFR, then maybe an EC or MAC3 is more suitable than DTPA. What are the information we get? So we get perfusion, we get GFR or ERPF, depending upon the compound we are using. We get renal function, total renal function, as well as differential function of each kidneys. We also get comment about the clearance excretion, and of course, there is a method called the indirect method of assessing vesicoureteral reflux, where once the radioisotope is accumulated in the bladder, then we make the patient pass the urine in front of the camera heads, and we can get an idea about whether it's in reflux or not. I'm not going to indication and guidelines because you guys are much more wiser in that regard. So you can have for various indication, including post-surgical assessments as well. Coming to patient preparation, very important, patient need not fast, should not fast, because if the patient is fasting and dehydrated, the scan quality will suffer. Hydration is extremely important, and our patient should be asked to drink plenty of water the day before, that day, and eat normally whatever they should not fast and dehydrate. In some infants, even we give IV hydration, when it's sometimes called as the well-tempered renogram, where we start IV hydration before starting the scan and then continue for some time. Now, catheterization is not routinely indicated for all patients, but in patients who have a grossly dilated ureter, especially lower ureteric system, in those patients, sometimes we need to catheterize the patient so that to evacuate the bladder, so that we can distinguish between VUJ pathology and bladder pathology. If a patient has severe reflux, in some patient we need to catheterize the patient, and patient with bladder dysfunction, dystonia or neurogenic bladder, sometimes we need to catheterize the patient. So if the patient you're advising for such patient where it might need catheterization, so discuss with your consultant nuclear medicine physician and then proceed accordingly. So this is a normal renal dynamic scan. You're seeing the perfusion phase, where you're seeing the vascularity. Then there is the uptake phase. The uptake phase is usually the initial after 1 minute phase of perfusion, and then you have a 2 or 3 minutes, 1 minute each. This is the total uptake phase. After that, the activity is excreted into the pelvic system, and this is the excretion phase. So you have a perfusion phase, the uptake phase, and excretion. You see the perfusion phase, the function in the uptake phase, and excretion in rest of the scan. So when we plot, what we do is we draw a region of interest around the kidneys, and then see how the radioactivity over those areas is changing with time. We plot against time, and this is called, it is a time activity curve, and we also call the renogram, which is so initially we have a perfusion phase, the phase 1, the uptake phase, the phase 2, and then the excretion phase of phase 3. This is how a normal kidney should function. You will uptake, then slow decline. This is a normal renogram. Then the term comes in diuretic renography. In diuretic renography, what we are usually doing is we are trying to increase the urinary flow and urinary pressure, so that we can differentiate between a dilated and obstructed versus a dilated and non-obstructed system. So that's the basic thing. Now, coming to diuretic renography, there are different protocols. The most widely used and commonly used is an F0 protocol, where you administer the radioisotope along with the diuretic, so that you don't need to prick the patient twice. Single prick is enough. Then there are other phases called, one is called a F+20, where you acquire the scan for 20 minutes. And if you see that the system is dilated and not clearing, then you inject the diuretic, and then again continue the scan for 20 minutes and see how the clearance is. Then there is an F-15 protocol, which is specifically used only in very selected patients where there's a hugely dilated system, and an F0 protocol is not sufficient. So very selected patient, maybe used for some patient in routine clinical practice. However, if you compare while based on literature, there's really not much difference between the three protocols, and F0 protocols is the one which is most commonly used. But of course, F15 might be required in some patients where you're suspecting that the system is dilated and not obstructed, and still you get obstructive features in F0. In those patients, you can repeat with an F15. So example, this is a patient you are acquiring without giving diuretic. You see a dilated system and it's not clearing. Then you administered diuretic around 20-22 minutes, and then you follow up it and you see that the system is clearing up. So this is what diuretic does: increases the urinary flow and clears up the dilated but non-obstructed system. Apart from the visual impression which we see, we also get some quantitative parameters from renal dynamic scintigraphy. There are various differential function that is most important and widely reported. Apart from that, you have a Tmax, the time required to reach the maximum peak, and T half, that is the time required from reaching the maximum peak up to half of it. This T half is also widely reported and used. Then there are some cortical transit time, some ratios, and if you are using DTPA, you can also get GFR. What I would like to highlight is, while quantitative parameters are important, they are not the sole criteria for classifying it as obstruction or non-obstruction. That is purely visual impression remains still the gold standard. Now, coming to T half, which is very important, especially in clinical practice. T half is, as I told, is like time required, at least the time activity curve comes to half of it activity. So now in normal person, it should be usually less than 10 minutes. If it is 10 to 20 minutes, it's considered an equivocal. And if it's more than 20 minutes, then system is usually obstructed. So that way it can help in, going one way or other. But as I mentioned, it is not the sole criteria. Now this is a renal dynamic scan of a patient. It was done with the technetium 99 ethylene cysteine. So this is the perfusion phase, and this is the uptake phase, and then the clearance phase. So what we see is that in the left kidney there is some function of both kidneys appears more or less relatively preserved. Then, but when we go to the clearance phase, we see there is some accumulation in the left kidney as well, while there is a large accumulation of tracer in the dilated right kidney. But then we keep it following up. The left kidney does not, the right kidney does not clear up, while the left kidney clear up. So that is classical for a dilated pelvic junction obstruction. When we see the curves, you see that for the left kidney, there is a rise and then the curves start falling. But for the right kidney, the curves keep on rising. When you see the T half, you see that for the left kidney, it is around 20.5, so equivocal or maybe clearance. But for the right, there it is, because the curve keeps on rising, so it is indefinite. So this is very classical for an obstructed upper urinary tract, that is a pelvic junction obstruction. And this is another patient. When we see the perfusion, we don't see the left kidney, while there is perfusion in the right kidney. In the uptake phase also, the right kidney is a bit enlarged, but showing relatively preserved uptake, but no major clearance till images. So there is some obstruction in the right. It is an obstructed right system, relatively preserved function, non-function in left kidney. However, when we see the delayed images, you see that you can also make out that left kidney is visualized. That is because once the dye from the right kidney, some amount of dye is gone into the bladder, and that is refluxed into the left kidney, which is leading it to its visualization. Here you see the curve of the left kidney, you don't see at all, so it's flat. For the right kidney, it rises and keep flat. This is an obstructed right kidney with preserved function and non-functioning left kidney. Then another patient with pelvic junction obstruction, in case left kidney PUJ, you see there is progressive accumulation over time. The curve is rising, while for the normal kidney, the curve rises and then falls normal. So this is a classical pelvic junction obstruction. I won't go into details of renal transplant evaluation, but we use renal dynamic scan for evaluation of graft function, including vascularity and function, and to assess for early and late surgical complication in case of renal transplantation. For example, in this patient post-transplant, day 7, renal dysfunction, you see the perfusion in the perfusion phase. You see the perfusion is quite nice, very well perfused, and even the uptake is quite good. You are seeing that there is good uptake, but there is no clearance. You don't see the bladder. Bladder is not visualized. There is no leakage into adjacent so all the tracer which is taken up is accumulated within the kidney. So that is under the rising curve. So that is very classical for an acute tubular necrosis. Now, another patient, in this patient, you see the perfusion is quite well. The tracer uptake in the graft is quite well. The function is also preserved. There's some activity going into the bladder. However, there is some leakage of the radioisotope from the urinary bladder or kidney into the adjacent. So this is a urinary leak or a urinome, as we call it. Then this is a late complication of post-transplant, that is a lymphocele, where a large accumulation is around the kidney. We are not sure whether it is urine or something else or seroma. In these cases, you will see the perfusion is preserved, uptake is preserved, the perfusion and function are preserved, and this collection which is around the post-transplant site, that is not showing any uptake. This is kind of photopenic, photopenic compared to the rest of the background. So this is a very classical for a lymphocyte, late complication. Now, moving on from renal dynamic scintigraphy, we move on to a renal cortical scintigraphy, which is usually done with 99 technetium DMSA or DMSA scan, as we reported. What DMSA does, it goes and binds with the renal tubules, and as in contrast to the RDS tracers, where they are significantly excreted into the excretory system, DMSA is very limited amount of DMSA is excreted into the excretory system. Most of it is in binds within the renal proximal tubular cortex. So we can get an assessment of renal function as well as some assessment of renal anatomy as well, more of a functional anatomy. So what are the indication of disease cortical scintigraphy? As we know, for acute renal infection or renal acute pyelonephritis, for assessment of a renal scarring or renal which is usually a sequelae of chronic pyelonephritis or some other injury. In post-treatment follow-up, a patient presented with an acute pyelonephritis, you saw some defect in kidneys on DMSA scan. Then you follow it up 6 months later to whether it has resolved or it has converted into a scar. And of course, in some patients with renal anomalies such as agenesis, ectopia, horseshoe kidney, you can also do renal cortical scintigraphy. For acute pyelonephritis, renal cortical scintigraphy is much more sensitive than most of the other available investigation, and usually the investigation of choice. It is usually performed during the acute stage of UTI to see whether there is any defect or not, and then a 6 months later it is repeated to see whether the defect persists in this case, which in case usually it has turned into a scar. Just based on DMSA scan, single DMSA time point scan, although we can indicate whether this is a pyelonephritis or scar, but exact differentiation just on a single time point DMSA scan is usually not possible. Now, in a patient with you do DMSA and UTI, this is a DMSA scan of a normal, completely normal. You see smooth cortical outline, good cortical tracer uptake. So the function is preserved and there are no photopenic defects, so no pyelonephritis or scarring. Now, in this patient, the function is preserved, but there is a diffuse photopenic defect in the left kidney, but the cortical outline of the kidney is maintained. So this is more likely to be an acute pyelonephritis. In another patient, the left kidney is smaller and scarred. Also, there are some so their scarring is already there, and there are also some photopenic defects you can make out there with a small scarred kidney. Now, just apart from the pyelonephritis or scar, there are other differential for a photopenic defect. There's include a cyst, a tumor, maybe a trauma, and hence most of these patients will have an ultrasound available as well for comparison, so that we are not misinterpreting the cyst and all for acute pyelonephritis or scarring. Now, these are DMC scan in some of the anomalies. So, a single ectopic pelvic kidney, you don't see any pressure uptake in the bilateral normal renal fossa. You see a large single pelvic kidney with smooth cortical outlines. There are some, you can see there are some small photogenic defects. You might misinterpret, but this is normal pelvic alical system. Since the kidney is a bit mal-rotated, so you are seeing this defect. This is not a cortical defect. This is more central. So it's physiological variation. Then, of course, there is the horseshoe kidney. You can make out in the horseshoe kidney. But here, you see the left moiety is functioning quite well, but the right moiety, the function is quite impaired. Just touching upon a direct radionuclide cystourethropy, this is very infrequently done nowadays, but you can do it. As the one I told of you about is like indirect cystourethropy, where you do a renal dynamic scan, the dye is excreted, the radioisotope is excreted into bladder is full, and then the patient voids in front of the camera. Here, what you do is you directly inject the radioisotope into the urinary bladder and make the patient void in front of the camera and acquire the image. So here you can see that there is a right-sided reflux going up to the renal pelvis. So to conclude, nuclear medicine can help you in addressing specific questions in your day-to-day clinical practice. But you should ask the investigation depending upon what are the information do you want, whether you want where perfusion is important for you, whether you want to assess the morphology, where you want to see the clearance, whether you want to know only the relative function, what is the status of the renal function of the patient, whether you want to quantify GFR or where just ERPF is enough, and whether you want to look for VOR. Depending upon what is your clinical question, you can select the agent and then ask for the test. So I'm done now. If you have any questions, any queries, we can just go on with it.
I must say this was an excellent presentation, Dr. Puneet. Cleared a lot of our doubts. So at times I face that in post-operative patients, the patients who have undergone a pyeloplasty, what is the follow-up schedule that you advise? So when do you want the urologist to do a DTPS scan in the follow-up?
If I were doing, I'd at least give a gap of 6 months.
Okay.
Even at 6 months, what happens is sometimes you can get a post-pyeloplasty pattern. But 6 months, I should at least wait.
Right. So 6 months we have to wait. Otherwise, your the DTPS scans might not be. I mean, they would still be, because of the inflammation, you would still have stagnation of the contrast into. And once you have I would just like to tell the students that the images are reversed as compared to CT scan on a gamma camera. So on a CT scan, the right side of your plate is the right side and the left side of your plate is left side. But on a gamma camera, it is absolutely ulta. So please do not misinterpret the images. Do not have the CT interpretation in your mind. So and if you're doing a pelvic kidney, the images look exactly as they look on the CT scans. So the right one is right, the left one is left on a DTPA on a gamma camera per se, but it's ulta on the CT scan. So just remember that. I think this was an excellent presentation. Thank you for your time on a Sunday morning, Dr. Puneet. If the students have any questions, we can ask them right now. Otherwise, we'll proceed to the next presentation, the last presentation of the day. If somebody has any questions? Right. So thank you so much. And let's move to the last topic of the day, which is called the basics in biostatistics. And may I invite Dr. Shabnam Ara for the presentation?
Sir.
Yes, please proceed, Yash.
I am having one doubt, sir.
Sure.
Hello.
Yes.
Hello.
Yes, you're audible.
Can you hear
Yes,
me,
you can ask the question. I think he's facing some technical trouble. So you can put that question into the chat box. I will address that with Dr. Puneet.
Sir, I want to ask that as sir has told about the protocols of diuretic implications,
as a 0 protocol, -15 and +20 protocol. But Campbell says that diuretic should be instituted when there will be maximum collecting system activity. So how will we see the maximum collecting system activity? And if we will have to follow the 0 protocol, then T-half will be calculated from the installation of diuretic and nucleotide only from the start, or we should see the maximum collecting system activity, then only we should instill the diuretic.
So classically speaking, we should not be giving diuretic to each and every patient, right? But for the sake of convenience, most of the centers, what they will do is they will do an F0 protocol. If you go by, if you want to inject the diuretic at the maximum pelvic system activity, then maybe an F+20 protocol will be more suitable for you. But when you see the literature and you see comparisons of all these methods, there is no major difference between whether you are saying it obstructed or non-obstructed, and depending upon which of the protocols you are using it, there is no clinical, in clinical practice, there is no major difference between the accuracy of this test. So that's why most of centers used to prefer an F0 protocol. But of course, if you want to inject diuretic at the peak, usually it is around F+20, where how the F20 protocol came in.
Right. So there are two more questions, Dr. Puneet, two quick questions. So any eGFR cutoff for a DTPA scan?
For the Indian population, usually a total on a DTPS scan, if it is more than 70, that's what the study at AIMS. So, but I think for most of the transplant workup panel, they use the total GFR cutoff of around 80, and of on each kidney having a GFR at least maybe around 40. That's the cutoff they use. But for Indian population, 70 is total GFR.
And any grossly hydronephrotic kidney, how we rule out the fallacies of DTPS scan? So I am unable to get this question, but I mean that is what the person has asked.
Sorry, we do DTPS scan, so that in a very grossly hydronephrotic we can rule.
Correct.
But of course, in a very small children, there may be difficult when the whether it is the ureter and the pelvic junction are so close, and if they're grossly directed, there might be. But in some cases, then those cases may be a catheterization of the urinary bladder might help.
And the last question is how the DTPA reading will vary in patients with and without PCN. So if somebody has a PCN, then how do you interpret it?
Just the similar way, because when we are drawing the graph, we are drawing it for individual kidneys. So if we are seeing where it is clearing, we don't know if it is clearing through PCN also, or it is clearing through the normal pathway. The curve will be the similar. If the PCN is obstructed, then you will see obstructive pattern. If the PCN is normal, then you will see a normal clearance.
You can even clamp the PCN if you actually want
to see the normal pathway, then you can do it.
Correct. Thank you so much. Thank you so much. And with this, we will move to the next presentation with Dr. Shabnam Ara. If you can stop sharing the screen, Dr. Puneet, please. So we will ask her to share her screen. Thank you. So Dr. Shabnam Ara, I think you are here. Yeah, you are there. Madam, can you please unmute yourselves and share your slides and the presentation, please?
Actually, I have having sharing these slides. Problem with sharing this slide. That is the main problem.
Oh, does Ruma has these slides? I mean, we can.
Okay, I'm. So I will send this Ruma to give me the email ID, or I can share in WhatsApp.
You can share it on the WhatsApp. I will try to share it from my end.
Or mail. I can mail you.
You can send it
WhatsApp
on. You can WhatsApp me. I'll do the rest. So on the faculty zone WhatsApp group, can you just mail me the presentation? I'll do the rest.
Okay. নাহলে আমি তো করতে পারবো না, আমাকে তো ল্যাপটপ থেকে করতে হবে না।
You can send it to Ruma and she will transmit it for us. Now Nara can send the material to Ruma, and Ruma will manage the show.
So whether the slides, I've shared the
I've got the
slides.
slides. I've got the slides. Just
Okay.
give me 2 minutes. I'm gonna
Okay.
share it from my end. Right, so let me just share the screen. Please be shared. The slides are visible?
Yes, it
Yes,
is visible.
visible, Tolu. It is visible.
Right. So,
Visible.
yeah.
Okay. Good afternoon, everybody. My topic is basics in biostatistics. So that topic itself requires two-day workshop, but I have to concise my topic, and I have asked Professor Ranjan De sir to give me the questions actually asked in their exam, and according to that questions, I have made some points. Okay, and discuss that thing only. So next, our learning objectives are different types of, what are the different types of clinical research? What are the different phases of clinical trial? Types of data, concept of central tendency means mean, median, mode, standard deviation, standard error, normal distribution and measures of dispersions. What is sample size and different sample technique, but in very brief. What is p-value and confidence interval? What is null hypothesis, type 1, type 2 error, some parametric, what is parametric and non-parametric test with some example, different types of study design in clinical trial, types of bias and ROC curve, also relative risk, odd ratio, sensitivity, specificity, positive predictive value and negative predictive value. Actually, these questions, these topics are given by SAT, that these questions are usually coming in the exam. So it is very difficult to cover all these things, but I will try to touch it. Okay, everything. So what is statistics? It is the science of collecting, organizing, and presenting, also analyzing and interpreting data to assist in making some more effective decisions. So what is data? Next, what is data? Data, actually, they are facts expressed in numerical terms, and data actually is a plural terminology. Singular term is the datum, and it has little meaning unless it is processed and become informations. Okay. So next is the, what are the different types of clinical research? First, we have to like assign, or investigator have to assign the exposure. When investigator assign the exposure, if then it will be the experimental study. Otherwise, if the investigator only observe the study, they has no power to assign which group are given this type of drug or this kind of surgery or not. That will be the observation study. Most of cases in our research or dissertation, we will do the observation study. The investigator did not assign the exposure. But on the other arm, in experimental study, the investigator actually assigned the exposure. Will giving the investigational drugs or new type of device or surgery, or other groups, the conventional things. Okay. And if they are randomly allocated, they are randomized control trial. Otherwise, it is non-randomized control trial. And in observation study, there may be some comparator group. If there is no comparator group, then it will be only the descriptive studies. But if they are analytical group, then according to the direction from exposure to outcome or outcome to exposure, it can be divided in three types, mainly three types. One is cohort. Cohort means the exposure to outcome. It is also like exposure has occurred and we are seeing whether it is the outcome is present or not. And case control studies, it is the retrospective, mainly the retrospective study, and core study is the prospective or forward looking study. In case control study, we from the that is the CM classes, we will know that from outcome to exposure. If cancer has occurred, lung cancer, we are seeing whether it is due to the smoking or not. That is a thing. And when exposure and outcome occur at the same time, that is the cross-sectional study. In most of our dissertations, we actually do the cross-sectional study because lack of time period. Okay. The level of evidence pyramid. any kind of studies, there are we should previously physicians said, we know that I have seen that that kind of things they are done. But now in modern medicine, we actually accept things according to the evidence, on the basis of evidence, and the level of evidence pyramids at the base, that the animal research or laboratory studies. Okay, then above it the background information or expert opinion about that things. Then next come into case series or case reports. Next is the case control studies. Now in the that's upper part is the cohort studies. After that it is random. Am I audible? Okay. Next is the randomized control trial. Okay, randomized control trial or RCT. And at the top, systematic review and meta-analysis. So at the top of evidence pyramid, it is the systematic review and meta-analysis. Okay. Next, level of evidence and grade of recommendations. When we are seeing any guidelines, they're giving the level of evidence and grade of recommendation. What does it mean? There are mainly 4 types of grades: A, B, C, D, and level of evidence are 1A, 1B, 2A, 2B, 3A, 3B, 4, 5, like this. So A means 1A, 1A and 1B. 1A means that is the topmost, uppermost, that part. Next slide, next slide. So grades are A, B, C, D, and level A, it is subdivided into level of evidence 1A, 1B. In 1A, there present interventions of systematic review of randomized control trial, and 1B, individual randomized control trial, not systematic review of randomized control trial. It is 1B is the only one randomized control trial. Next, B are subdivided into 4: 2A, 2B, 3A, 3B. Individual randomized control trial, systematic review of the cohort study. 2B is the individual cohort study. 3 is the systematic review of case control studies. 3B is individual case control study. According to their intervention, level of evidence are 3A, 2A, like this, and grades are B, C, etc. Next, C is the case series. That is the level of evidence 4. And D means expert opinion or level of evidence is 5. Next, outcome measure of observational study. Observation, what are the observational studies? In analytical studies, group of observational studies, there are 3 types of observational studies we actually seen. One is the case control, cohort, and cross-sectional. In cohort studies, mainly the outcome measures are by relative risk or RR, and case control studies by odd ratio. Now, relative risk is the incidence of outcome with exposed, and incidence of outcome divided by incidence of outcome without exposure. Okay, so express how many times more or less likely an exposed person develop an outcome relative to the unexposed person. So it indicates the incidence of outcome express the person develops an outcome develop an outcome is according to the exposure. So when we say relative risk is 1, that means incidence risk of outcome is there is increased risk of outcome after exposure, and 1 means no risk of outcome, but less than 1 reduced risk of outcome. Next is the odd ratio. Odd ratio is divided by odds of even in another group not exposed. It is in epidemiology, in case control studies, when the incidence is not available, then relative risk cannot be calculated directly, because in relative risk, we calculate the incidence. So in odd ratio, from case control study, we actually measure the odd ratio. So odd ratio, odd of exposure among cases and odd of exposure among control. So it is AC by BD or AD by BC. We know from our CM classes. Now, relative risk is the incident exposed. So in ratio, in case control studies, there is incidence, so we use odd ratio. Relative risk is the incidence among exposed by the That they are the other thing. It is measure of the strength of association between risk factor and outcome, and it is closely related to relative risk. Okay, so relative risk in case of cohort and odd ratio in case of case control, but odd ratio can be used in case of case cohort also. Now, let's discuss what is clinical trial. In clinical trial means a new drug or investigational new drugs that is systematic study of that drugs to in human subject to generate data for discovering or verifying its clinical, pharmacological, and adverse effect with the objective to determine its safety, efficacy, and tolerance of such drug or investigational new drugs according to new drug guidelines. Now, next slide. Before starting clinical trial, some molecules are some preclinical studies are required. Some like random selections or any kind of serendipity or enzymes that are targeted, and through high throughput screening, that compounds are like go through lots of reaction, chemical reactions, and different kinds of analysis, and then the lead compound are identified. Then among 1,100 lead compounds are identified, then dozens of like 10 to 12 compounds are optimized. Then candidate drug maybe 1 to 3. Next, after finding that candidate drug, we are doing that with that molecule in preclinical animal studies. Okay, preclinical studies, and next after the preclinical studies, we are finding any efficacy about or any kind of positive interpretations from that study, then we are going to the clinical study in human subject. Okay, and there are mainly 4 types of clinical trials. Okay, so but next slide. Okay, next slide. But there are mainly 4 types: phase 1, 2, 3, 4. But there are one phase is called phase 0. It is also called microdosing. Okay, microdosing. Its objective are ensured whether the investigational product will work as expected or not in the human body. Actually, very small amount of the investigational drugs, and in smaller group, 10 to 15 healthy humans with very shorter period of time, mainly 1 week or 10 days, they are given very little dose, and they find that mainly the sponsor, they actually doing their that is the primary, or that is the trial. Before doing in actual trial, they actually seeing whether that drug has capability to do any kind of efficacy or safety in human subject. Then they will go to the phase 1. It is not done for any drug to find any drug approval from the DCGI. It is only done by the sponsor. It helps them to reduce their expenditure and time, because at this level, if they found that this is not very helpful, they will go or non-go. That phase they decided. Okay, it is only for the sponsor. Okay, but not regulatory purpose. Next, phase 1. Phase 1 actually, their objectives are to find the safety, tolerability, pharmacokinetic, dynamic, and dose range. And here they are selected the healthy individual, 20 to 50, not 100. And here the patient volunteer are some exceptional. We can use healthy volunteers. Other than healthy volunteer, patient can be in phase 1 trial, like AIDS patient, HIV patient, or tuberculosis patient, or cancer patient. We can do the study in that healthy subject, because they are the defined kind of chemical subject which can harm to the healthy volunteer. So in that case, only patient can be used as volunteers, like in case of cancer trial, in case of drugs help in the AIDS patient or tuberculosis. And they are mainly open trials, okay? And it requires 6 months to 1 year. It is a first exposure to human to make decisions about drug safety. It is mainly deal with the safety issues. Next is the phase 2. Subjects with specific disease area to explore the clinical potential of a medical product. It is also called efficacy proving trial. Okay, whether the drug shows any kind of exploring the efficacy. Okay, it is not confirming, but exploring the efficacy. But safety is always there in every phase of study. Safety is always there. So exploring the efficacy in phase 2 trial, and the subjects targeted disease conditions are the subjects, and small group 100 to 200 or 500 among that group it is done, and it is blinded, but normally they are not double blinded or randomized control trial. Mainly randomized control trial are done in case of phase 3 trial. Okay, so next is the phase 3 trial. Phase 3 trial generally take 1 to 4 years for its completions, and it is also called efficacy. That was actually gather more information about safety and efficacy of the product, and it determine the dose response relationships and rare side effects. Okay, and after phase 3 trial, actually they submit the investigator and sponsor, they submit all that report, that preclinical and clinical phase 1 to 3 to the drug controller authority, that is DCGI in case of India, or CDHCO. And after scrutinizing all this report, that can be approved or not approved. According to that, it is then we can do phase 4 study. So phase 4 study, they actually did continue collection of information about safety and efficacy of newly launched product. After the drug is approved, the phase 4 trials are done to identify rare adverse effect and whether any dose recommendation needed or risk benefit relationship, understanding various populations. Okay, so next is the types of data. There are qualitative data and quantitative data. Okay, so qualitative data are nominal data. Nominal and ordinal. Nominal means name, so like gender, hair color, ethnicity, they're nominal. And ordinal means or in order, first, second, third, or grade, or economic status, low, medium, high economic status, that kind of ordinal data. And also this is the qualitative data. And quantitative data, it may be discrete data and continuous data. Discrete means the number of students in a class. Okay, discrete. Okay, the number of workers in a company, the number of home runs in a baseball game, it is a fixed number. Okay, and continuous data mean height of the children. Height of the children may be increasing, and the square footage of 2-bedroom house, the speed of cars, that may be point something. So continuous data and discrete data are there in quantitative data. Next are the primary data. Primary, what is primary data? It is the collected from first-hand through personal experience of evidence. That is raw data on first-hand informations from survey, personal interview, case studies, census, primary data. And secondary data, it is accessible in the form of data collected from primary sources, from books, from journals, from census publications. They are collected. Next is the what are the different type of statistics? One is the descriptive and another is the inferential. Descriptive means that methods of organizing, summarizing, presenting data in an informative way. And inferential means that determines something about the population on basis of sample. Inference are drawn from the sample. So it depends on the population and sample. So what is population? Populations before the last slide, previous slide. Go to the previous slide. Okay. So population, the entire shade of individual or objects of interest or measurements obtained from all individual or object of interest. It is a population, the entire set of individual, and sample, a portion or part of the population of interest are taken. Okay. So why we study statistics? Data. Next slide. Next slide, please. Okay. So data are everywhere. Statistical technique are used to make many decisions that affect our lives. An understanding of statistical method will help us to make this decision effectively. So inferential statistics for estimation and hypothesis testing. Now, this is the population on the next. Population on the left-hand side, patient with COPD. And sample is the some 972 patients with COPD in a clinical trial. We select the sample in some sample size calculation technique. Then inference based on the sample, we found that proportion of FEV1 on the responder. Okay. Next is the sampling. A sample should have same characteristic as the population it is representing. It can be with replacement or without replacement. There are random or non-random method, and there are sampling errors existed. Okay. Next, random sampling method. There, we all know there are some simple random sample, stratified, then cluster. Stratifieds mean divide the population to group called strata and then take a sample from each strata. And cluster means divide the population in strata and then randomly select from the strata. These strata are in the cluster sample, like in vaccination immunization program, cluster samples are. Then systematic sample, randomly select in starting point and take every 9th or some number piece of data from a listing of the population. It is a systematic sample. Next is the descriptive statistics. In descriptive statistics, there is no comparison. So we collect data, present data like table, graph, summarize data, sample mean in that way. Next is the data, the defined type of. Next slide. Okay. So statistical data are usually obtained by counting or measuring item. Most data can be put into the following categories, that is qualitative and quantitative. I have discussed this already. I've already discussed it. Next slide. Qualitative data can be dichotomic. Okay, dichotomic. If it takes the form of a word with two options, like gender is the male or female with yes or no, like this, or polynomic. Polynomic means if it takes the form of word with more than two options, like education from primary school, okay, or secondary school or university. No, previous slide, qualitative data. Okay, so dichotomous means two options are there, only male, female, or yes or no. Or polynomic means there are educations from primary school, secondary, university, or any other type of. So these are the things in qualitative data. And quantitative data, there are discrete or continuous. Discrete means if it is the result of counting the number of students of a given ethnic group in a class, the number of books. So it is counting the number of students. It is a discrete or fixed. And continuous means if it is the result of measuring, that is distance travel. Okay. Next is the continuous. Next, types of variables. So variable means varies. So if data depend on some variable, so that is called variables are qualitative or quantitative. It may be dichotomous or polynomic, dichotomic or polynomic. I have discussed it. And quantitative, that is discrete or continuous. Next slide. So next slides are same. Next, numerical scale of measurement. There are nominal scale, ordinal, interval, and ratio. I'm not discussing in details. Next slide. Next slide. Frequency distributions, numerical presentations of quantitative data. are frequency distributions. And when raw data are measured on quantitative scale in interval or ratio category, they can be the design for the data values before a frequency distribution can be formulated. Next is the data presentation. Data presentation are graphical, two type of statistical presentation, graphical or numerical. Next slide. So histogram, next slide. Histogram is a graphical display of data using bars or different heights. In a histogram, each bar groups numbers into range. Taller bar shows that more data falls in that range. Next is the box plot. It is very important. Box plot or box and whisker plot or box whisker plot. It gives a good graphical image of the concentration of the data. They also show how far the extreme values are from the most of the data. A box plot is constructed from 5 values: the minimum value, first quantile, median, third quantile, and maximum values. This is the box. Next is the box plotting. So the image above is a box plot. A box plot is a standardized way of displaying the distribution of data based on the 5 number summary. That is minimum, first quartile, median, third quartile, and maximum. It can tell you about your outliers and what their values are. It also tell you if the data is symmetrical and how tightly your data is grouped and how your data is skewed. So box plotting is very important. Next is the histogram. I have already described. So next slide, histogram. Next slide, frequency polygon. Frequency polygon. This is the frequency polygon. Okay, next slide. Okay, it is a frequency. I have already given you the PPT, so you can. Next is the pie chart. You all know about the pie chart. I'm not discussing this. Next slide. This is a pie chart. Next, bar chart. Next slide. Bar chart. These are the bar chart. Next is the time series graph. Time series graph. Yes. Okay. Next is the scatter plot. Okay. What is scatter plot? It shows the relationship between two variables. If there are two variables, one dependent, one independent, on the same set of individual, then we use the scatter plot. In the x-axis, or that is called the abscissa, and y-axis the ordinate, two different variables are plotted. By convention, independent variable is placed on the x-axis and dependent variable in the y-axis. Here, weight being an independent, weight is the independent variable, is placed on the x-axis, and blood pressure is the dependent variable. It is placed on the y-axis. Okay. So scatter diagram is very important. Next is the diagram of forest plot. Forest plot is a graphical, or it is a pictorial presentation of meta-analysis. Okay. On the left-hand side, we found that there are some atoll, means in chronological order. They actually depict like that left-hand column lists the name of the studies commonly in chronological order from top downward, while the right-hand column, a plot of measure of effect. Okay, plus it measures the effect in odd ratio for each of the studies. It is represented by the square. Okay, the odd ratio for each of the study, that is the measure of effect. It is represented by square, and it incorporating confidence interval represented by horizontal line. And overall measure of effect is plotted as a diamond. Lateral point indicate the confidence interval. Okay, so it is very important. We should interpret how we should know how to interpret the forest plot. On the left hand side, the studies, name of the study is in chronological order from top to downward, they are listed, and the right hand column, they plot the measure of effect of odd ratio for each of the studies, that is represented by square, and that incorporating confidence interval by horizontal line, and overall effect is plotted by diamond. Okay, this is the next is the measure of dispersion. Dispersion is the state of getting dispersed or spread. Statistical dispersion means the extent to which a numerical data is likely to vary about an average value. In other words, dispersion helps to understand the distribution of the data. We all know about the normal distributions and skewed distributions. Okay. Next is the next slide. About the parametric assumption of parametric test. Assumption of parametric test, samples have been selected from the population randomly, and the variables follow the normal distribution. The variance, that means squares of standard deviation of different age groups, are equal. And the descriptive, next is the descriptive statistics. Their continuous variables are mean, median, and standard deviation. We all know what is mean, median, and then standard deviation. Next is the measure of dispersion. The types of absolute measure of dispersion are range, variance, standard deviation, quartile and quantile deviations, mean and mean deviations. Next is the what is normal distribution. So the normal distribution is a Gaussian or bell-shaped curve. They are symmetrical, unimodal, and it is described by mean and standard deviation. 95% of observation lie within the 1.96 or 296 or 2 standard deviation on either side of the mean. Okay, so next is the standard deviation. Standard deviations mean a measure of the spread of group of individual observations around the mean. And standard error, it may be 1 standard, 2 standard, or 3. And standard error, a measure of spread of distribution of the mean. Okay, next is the p-value. Okay, p-value, it indicates the probability of the result occurring by chance alone. If the probability or p-value is less than 5%, is very important. If the probability is less than 5%, that is 0.05, we conclude that there is a significant difference between two groups or intervention. Okay, but still there is 5% probability that it can happen by chance alone. If we are concluding there is no significant difference, that is p more than 0.05, we should calculate the power and confirm that study was adequately powered. So power is very important. If it is adequately powered, then we can say that there is no significant difference if p is more than 0.05. Okay. Next is the misinterpretation of the p-value. The p-values does not tell anything about the effect size, that is mean difference about the two groups. A significant p-value, that is statistical significance, does not mean clinical significance. Next, how to report p-value. Okay, how to report the precise p-value and not only the precise p-value, not the range. Like confidence interval is the range, but p-value is the precise p-value. It is unnecessary to go beyond the 3 decimal. Okay, still lesser values can be indicated as p less than 0.001. Some statistical package gives small values, p equal to 0.00. This should be reported as p less than 0.001. Next is the confidence interval. It provides a measure of the degree of precision for an estimated parameter. The desired degree of precision can be specified. Most commonly, 95% confidence intervals are used. So how it interpret? If a trial was repeated a large number of times, 95% of the calculated confidence interval could contain the true value. So it means if we repeat the test in 95%, 100 times, 95% times, it will be the true value. Okay. So next is the interpretation of the confidence interval. As it is impossible to study the entire population, we take a sample and draw conclusion from it, but make inference to the entire population. As we are not testing the entire population, we cannot make inference with 100% certainty. Hence, we attach a certain level of confidence to estimate population parameter. Okay, and 95%, next is the 95% confidence interval, indicate there is 95% chance of including the population parameter in the given interval. Okay. Next is that what are the difference between p-value and confidence interval? P-value provides less information than confidence interval, and p-value provides only a probability that estimate is due to chance. A p-value could be statistically significant but of limited clinical significance. But clinical, that is confidence interval or CI, They provide a range of plausible value of population mean, and it contains the true population value 95% of the time. And if confidence interval range is very wide, then plausible value might rare from very low to from range from very low to very high. Okay. Then hypothesis testing. We all know about null hypothesis, means no difference in mean response between treatment and comparative. We assume there is no difference between treatment and comparative. And alternative hypothesis, that is HA, it means there is a difference in mean response between treatment and comparative. We aim to show from the trial result whether or not, that is null hypothesis, is true. Similar to legal trial, null hypothesis means similar to legal trial, innocent until proven guilty. So we assume that there is no difference between treatment and comparator. Okay. So next is the types of error. As we always experiment with samples and generalize to population, error can creep into our inference. There are two types of error, alpha and beta. And the decisions like null hypothesis, when the null hypothesis is true, but it is rejected, then it is called type 1 error or alpha. And null hypothesis, that is the beta error, type 2 or beta error, when null hypothesis is false and it is truly, and it is thinks that it is true. So type 1 error is the false positive. Okay. So it is more harmful because consumer risk, because the results are false positive. Okay. So consumer risk, regulator concern, sponsor risk, continuing developing that will later fail. That's thus wasting resources and funds. And type 2 errors, that is false negative. It causes sponsor risk, stoppage development of a drug that would have succeeded. That's losing potential future revenue. But that means it will have some future, but we falsely make it false negative. It means it can help, but we falsely negate that hypothesis. Okay. So type 1 error is more harmful, not type 2. Next is the design consideration clinical trial. The most important design technique for avoiding bias in clinical trial are blinding and randomizations, and they should be normal feature of most controlled clinical trial that intended to include in a marketing applications. Next is the power. Power is the chance that the trial, because I have lack of time, I have to just read out the slides. So power is the chance that the trial will be successful if the treatment is as effective as we expect. And power should be usually between 80 to 90% to detect the treatment effect of a magnitude viewed as clinically meaningful. Okay. Next is the commonly used phase 3 designs. They are parallel, withdrawal, group or cluster, randomized, crossover, factorial, large sample, equivalence or non-inferiority, and sequential or superior trial. Okay. So I am discussing, I am depicted only the parallel and crossover design. I think all you know about the parallel and crossover design. Next is the randomizations. Next slide. Randomization ensure each patient has a chance of being allocated to any of the treatment group. And what is blinding? It refers to the withholding information about assigning treatment from trial participant. It may be single or double blinded when investigator did not know about that who will assign the treatment or that placebo group. And this is actually blinding safeguard against bias. And double blind, neither the patient or investigator or accessor knows the treatment assignment. Okay. Next is the types of statistical software. There are lots of statistical software like SAS, S+, R software, Minitab, Stata, etc. But most important are usually commonly used are MS Excel and SPSS. Okay, and some useful websites and for more information of statistical softwares I'm giving that link. Now, next is the major sources of bias in clinical research. Okay, pre-trial bias means before the trial is beginning, there are some biases like flawed study design. If we not design it properly, next is the selection bias. If we not select the inclusion according to inclusion exclusion criteria are not selected properly, that will be there may be some biased, and channeling bias also there. And next is the trial implementation. During the trial, that interviewer bias, chronology bias, recall bias, transfer bias, misclassification of exposure and outcome, and performance bias. And bias after trial, there are citations. Citation bias during publications or confounding biases are there. Data analysis and publications. Next is the type of parametric test. According to the number of groups, if there is one group, so in parametric test, if one group and two data set before and after, we actually use pair t-test. And in one group, if there are two data set, then we use the repeated measure ANOVA. And in two groups, unpaired t-test, and more than two group analysis of variance, that is ANOVA. Okay, next is the non-parametric types of non-parametric test. In one group, two data set before and after, that is the Wilcoxon test. That is the counterpart of t-test in parametric. And more than two data group, that is the Friedman test. In two groups, if there is two groups in non-parametric test, then Mann-Whitney U test. And more than two groups, that is Kruskal-Wallis test. Okay. Next, student t-test. What is student t-test? In 1890, William Gossett studied the distribution of means from small sample, less than 30. He found that the means are no longer normally distributed and described a new distribution called t-distribution. He published this under a pseudonym as student. And according to this, it is called the student t-test. Pair t-test, a pair design, the inter-subject variation between groups are avoided as each subject act his or her control. Hence, certain modifications are made to detect change that might be obscured by inter-individual variation between the groups. Next is the analysis of variance or ANOVA. There are four different groups, A, B, C, and D, and we want to compare the anti-hypertensive effect. What is wrong if you do the multiple t-test like A versus B, A versus C, A versus D, B versus C is like this? It will actually, next. The rate of error increase exponentially with the number of tests conducted. For four groups, it is given as 1 minus 1.05 to the power 4 or 0.18. This high error rate is not acceptable. So, analysis of variance, compare the variance between the different group with the variance within the group. The ratio is called F. And the ANOVA perform an overall global assessment followed by individual assessment. And if there are table also for F tables are there. Okay, now types of ANOVA according to like one factor, if the factors are one, and in parametric test, one-way ANOVA, non-parametric test, that is Kruskal-Wallis. Two factor, two-way and two-way ANOVA, one factor pair design, that is repeated measure ANOVA, and non-parametric, that is a Friedman test, and more than two, that is multifactorial ANOVA. Okay. Next, post hoc test for ANOVA. Okay. So it should be described, but it should be discussed properly, because only that parametric, non-parametric takes one classes. Okay. So you should have some brief overall knowledge about it. There are some post hoc tests for ANOVA. The names are Dunet's, Tukey's, Bonferroni. Okay. So next is the non-parametric test, also called distribution-free test. No rigid assumptions about the distributions of data. Answered the same sort of question as that of parametric test. For each parameter test, there is a non-parameter counterpart. Next, when to use non-parametric tests. Assumptions of parametric tests are violated. That is, they are not normal or skewed distribution or unequal distributions. Okay. Next is the advantage of non-parametric test, non-numeric data, like taste of food, non-palatable, good or excellent can be analyzed. And since the inference is based on rank, it is less subject to measurement error. Involves simple computation than corresponding parametric tests. But there are some disadvantages. Less powerful or efficient than parameter, tend to waste information as it deal with rank, not actual facts. Okay. Next is the next slide. I will skip that slide. Next slide. The difference of mean difference in two group. So if it is done Z test for mean for large sample group and student T test for small sample group, and independent samples then unpaired are same sample before or after paired T test. Difference of mean between more than two groups, they are used the ANOVA F test. Independent samples one way ANOVA or n way ANOVA, they are two way or three way. Okay, and also there was a term MANOVA. Next, the test of significance. What are the difference between parametric and non-parametric? It is asked very often in exam. Parametric for continuous data, they are normally distributed data belonging to interval or ratio scale, and they are more powerful. And non-parametric for discrete or continuous data, they're not normally distributed, less powerful. No, some they are not assumed that they are normally distributed. Okay, and they are the example of non-parametric and parametric test. Next slide. Steps in test of statistical significance. State the null hypothesis, then state the alternate hypothesis. State the level of significance, p-value or probability, or type 1 error or alpha error. Then compute the test statistics and criteria ratio. Find out the p-value and interpret it. Okay. Then rejecting null hypothesis. I'm skipping this slide also. Next slide. Next slide. Sample size calculations. There are 4 procedures that could be used for calculating sample size. Use of formula, ready-made tables are there. There are some nomogram, computer software. The appropriate sample size population-based study is determined largely by 3 factors. The estimated prevalence of variable of interest, desired level of confidence, and accepting margin of error. Next is the sample size calculation required parameters. The parameters required, the size of difference to be detected, and the standard deviation of parameter to be measured, type 1 error rate, and type 2 also, and sample size of the mean. And this is the way the n equal to z square by z square into variance square by e square. Z is the confidence level of 95%, variance of population VR, and E for allowable error. So this is an example. A health officer wishes to estimate the mean hemoglobin in a defined community. The preliminary information is that this mean is about 150 milligram per liter with a standard deviation of 32 milligram per liter. If a sample error of up to 5 milligram per liter in the estimate is to be tolerated, that is allowable error, how many subjects should be included in this study? Here standard deviation is 32, E is the 5, Z is the 1.96. Okay. So this is the how this is sample size of mean is calculated. And sample size for proportion and prevalence are calculated by this formula. Next, sample size for two mean are calculated by mean. So there are, it requires lots of like example, then we can discuss this, but now it is not possible to all these things. Next is the sensitivity. Next slide. Sensitivity and specificity. Measure how good a test is detecting binary features of interest, means that disease or no disease. Next term is the true positive, sick people correctly identified as sick. False positive means healthy people incorrectly identified as sick. Then true negative. True negative means healthy people correctly identified as healthy, and false negative means sick people incorrectly identified as healthy. These are the terms we should know. And this is the 2x2 contingency table. The test positive, test negative, and disease present that is the A, B, C, D. And from this we can estimate the sensitivity and specificity. Okay, next is the specificity. Next sensitivity, specificity. Next is the positive predictive value. Next is the negative predictive value. Okay. Next is the ROC curve. Okay. ROC curve, that is also called receiver operating characteristic curve. A receiver operating characteristic curve or ROC curve is a graphical plot. It illustrates the diagnostic ability of a binary classifier system as its discrimination threshold is varied. The diagnostic performance of a test or accuracy of a test is to discriminate disease cases from normal cases is evaluated using the receiver operating characteristic curve analysis or ROC curve analysis. A receiver ROC curve is a way to compare diagnostic test. It is a plot of true positive rate against false positive rate. Next, history. According to history, the receiver operating characteristic come from signal detection theory developed during World War II for analysis of radar image. Radar operators, they decide whether a blip on the screen represent an enemy target. Signal detection theory measured the ability of radar receiver operation to make these important distinctions. And their ability to do so was called receiver operating characteristic. It is not until in 1970s that signal detection theory was recognized as useful for interpreting medical test results. Achha, an example, I am skipping these things because it requires time. So you can, next is the next slide. Actually, on the y-axis, there is sensitivity, in the x-axis, that is 1 minus specificity. Okay. So I'm giving that PPT so you can read this PPT. Okay. If you are want to know more about ROC. Okay. So ROC interpretation of ROC curve, it is very important. A ROC curve of random classifier. A classified with the random performance level always shows a straight line from origin. That is 0.0 to top right corner, 1.0. Okay. So two areas separated by ROC curve. A simple estimation of the performance indicate a simple estimation of the performance level. ROC curve in the area on the top left corner that indicate good performance level, where in the other area it is the poor performance level. Okay, next, area under the ROC curve score. Another advantage of using ROC curve plot is a single measure called area under ROC curve score. As the name indicates, it is an area under the curve calculated in the ROC space. Okay.
Hello.
Hello. Next, summary. Next slide. Last slide. Summary. So we are discussing these things, and take-home messages are the next slide. Next slide. Take-home messages are statistical tests provide an objective way of deciding whether the result obtained are really due to intervention or merely due to chance. And statistical method, which was population parameter, are called parametric test. Random sampling, normal distribution, equal variance are the assumption of parametric test. Unpaired t-test, paired t-test, ANOVA are some parametric tests. Wilcoxon test, Mann-Whitney test, Kuskal-Wallis test are some non-parametric tests. P-value indicate the probability of result occurring by chance alone, and 95% confidence interval indicate there is 95% chance of including the population parameter in the given interval. Thank you all. Okay. I know it is a biostats, and that part you have given me that thing, like these are the questions usually asked. It requires like 1 or 2 days discussion. So I am trying to jot down the things and giving you the PPT so students can read. I'm just discussing the brief outline and they can read from the slides. Okay. Have a nice day.
Thank you, Kamal, for your great effort, and I think students are benefited by your effort. Actually, at least they should know what they have to read for facing the examination. And you have your slides will be always available with us. They can always take
That's why
help of your.
I am studying with you, sir. So they can.
Yeah.
It will be in
your class will be kept in our archive for future students to also consult in your class. And thank you, Torun, at the end for helping the entire EZUSI education system for a long period. And I also thank Onurima and Puneet for their kind participation in today's class. Thank you. Today is the last part of our academic session for this year, and hope students have benefited from it. And I really thank all of you for giving support to the educational effort of the East Zone Urological Society. Over, Tarun.
Thank you so much for this wonderful opportunity, sir. I am very sure that these students are certainly benefited. They can always reach back to the archives because this will be available on the official website also. And I hope next year also we are able to do much better than what we have done this year. With all the best wishes to the examining students.
Thank
Good
you
luck,
very
sir.
much. Thank you, Dr. Ranveer Prasad Singh, for to be with us and actively participating in our teaching program. And hope you will be always be a part of our teaching program. I don't know, the next secretary will hopefully continue this lovely session for the coming years. And with this, we conclude our academic session. And thank you once again, all of you, those who have participated in the previous classes also, and also to the students for taking active interest. Thank you.
Thank you so much, sir. Good day, sir.